The subcommittee will come to order. Chair recognizes himself for 5 minutes for an opening statement. Quote, if you like your current plan, you will be able to keep it. Let me repeat that. If you like your plan, you will be able to keep it, end quote. That was remarked by President Obama at the White House on July 21 of 2009. Another quote, if you like your insurance plan, you will keep it. No one will be able to take that away from you. It hasn't happened yet. It won't happen in the future, end quote. President Obama in April of 2010. Despite these claims, repeated claims, it has become abundantly clear that if you like it, you can keep it. Promise to the American people has been broken. By the administration's own estimates, 49 to 80% of the small employer plans, 34 to 64% of large employer plans, and 40 to 67% of individual insurance coverage will not be grandfathered by the end of 2013. A May 2011 PricewaterhouseCoopers survey of employers also echoes the administration's warnings. Of note, 51% of the employers surveyed did not expect to maintain grandfathered health status, meaning their employees would forfeit their current coverage and pay higher premiums due to the health care laws' mandates on their new coverage. Because grandfathered plans are subject to many of PPACA's requirements, employers today are forced to pay more to keep their current grandfathered plans, shop for more expensive plans, or drop coverage for their employees altogether. The discussion draft before us today simply prevents the administration from implementing its June 17 interim final rule, and it prevents the administration from imposing any standards or requirements as a result of PPACA on grandfathered health plans. That way, consumers who really do like the coverage they have really get to keep it. As for the medical loss ratio, Section 1001 of PPACA requires health plans to spend 80% for plans in the individual and group market and 85% for large group plans of premium revenue on medical care beginning this year. Plans that fail to meet these thresholds are required to rebate the difference to their consumers. Supporters of this section claim the medical loss ratio regulation was designed to protect consumers from unscrupulous insurance companies. However, it actually contains perverse incentives for insurance companies to ignore waste and fraud, which drives up premiums and co-payments for consumers. Under the regulation, investments in fraud detection and even quality improvement and care coordination fall under administrative expenses, which can only make up 20% of plan spending. Plans struggling to make the 80 to 85% threshold for medical cost often can't risk these activities, which could save consumers money and provide them with a higher quality of care, for fear of being penalized and having to pay rebates. Even worse, if a plan does identify fraud, cutting those fraudulent payments and activities actually reduces their amount of spending on medical cost, making it even harder for them to reach the 80 to 85% threshold. Consumers, not HHS and government bureaucrats, should be deciding what health care spending is appropriate and what health care spending is not appropriate for their plans. Plans should be able to invest in waste, fraud, and abuse detection without worrying if that spending puts them in violation of a governmental regulation. And consumers should be free to select those plans that share their priorities, not the government's. Again, while the medical loss ratio has been billed as a tool to protect consumers from insurance companies, many states are clamoring for waivers to exempt their citizens from these protections. The Secretary of HHS is empowered to grant MLR waivers to states that can prove that meeting the 80 to 85% thresholds will destabilize its insurance market. Currently, HHS has granted MLR waivers to 5 states: Maine, New Hampshire, Nevada, Kentucky, and Iowa. With these waivers, consumers in these states are now protected from one of the health care law's key consumer protections. Residents of North Dakota and Delaware are not as lucky. HHS rejected their waivers. 9 more states, Florida, Georgia, Louisiana, Kansas, Indiana, Michigan, Texas, Oklahoma, and North Carolina, have determined that their insurance markets will be destabilized by having to comply with the MLR regulation and have applied for waivers. They are still waiting to hear back. The MLR regulation is also costing jobs at a time when unemployment remains stubbornly above 9%. HHS's interim final rule on MLR includes health insurance agent and broker commissions in the administrative cost category. Many plans, desperate to meet the 80 to 85% threshold, simply cannot afford to use brokers and agents as they once did. One estimate from the National Association of Health Underwriters suggests that more than 20% of agents will have to downsize their businesses as a direct result of this calculation. I strongly support H.R. 2077, introduced by Dr. Tom Rice and Representative Kathy McMorris Rogers, which repeals the section of the Public Health Service Act dealing with MLR requirements, which was added by the new health care law, and I would urge my colleagues to support it. Finally, I'd like to thank all of our witnesses for being here today and yield back my time, and now recognize the ranking member of the subcommittee, Mr. Pallone, for 5 minutes.
Thank you, Mr. Chairman. I'm extremely disappointed in today's hearing topic because for too long, too many hardworking Americans paid the price for policies that handed free rein to insurance companies. And so Democrats did something about it. We passed a health reform law that gives hardworking families the security they deserve. But here we are once again as congressional Republicans introduce new piecemeal repeal legislation to take these protections away. The result of such legislation is putting insurance companies, not patients, back in control. The two bills under discussion today support what I've been saying all year long. If the Republicans had their way, insurance companies would have free rein to drop someone's coverage unexpectedly when they're in an accident or become sick because of a simple mistake on an application. If the Republicans had their way, over 1.2 million young adults would lose their insurance coverage through their parents' health plan as their children work to launch their careers. And if the Republicans had their way, insurance companies will once again be allowed to deny health coverage to a breast cancer patient who was in remission but now needs to restart her chemo, and to put an annual cap on the amount of care she'll have access to, or even worse, a lifetime limit on her health coverage, so in a desperate time of need, she has to choose between bankruptcy and getting life-saving care. If the Republicans had their way, insurance companies will once again have the ability to freely raise patients' premiums, likely by double digits, and have no restraints or accountability on what proportion of these premium dollars are spent on health care services. Now, I'm not going to stand silent while the repeal Republicans work to rescind the Patients' Bill of Rights and leave tens of millions of Americans at the mercy of the insurance companies. Enough is enough. Let's move on to the real priorities of the American people, and that is jobs, 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 jobs. Thank you, Mr. Chairman. I'd like to yield the time that I have left to the gentlewoman from Illinois, Ms. Schakowsky.
I thank our ranking member very much for yielding to me. Well, here we are again. And what we're witnessing once again today is an effort by the Republicans to do the bidding of the insurance companies at the expense of ordinary consumers. The idea of a medical loss ratio says that we're just not going to let the insurance companies charge whatever they want. That legislation, that rule, the medical loss ratio, holds insurance companies accountable and ensures that healthcare consumers receive the services for which they are already paying top dollar. By law, insurance companies have to spend at least 80% of their premium dollars on medical care and health quality improvement as opposed to administrative costs, marketing, executive salaries, and bonuses. I'm so glad that we're going to hear from somebody who's had years of experience in the insurance industry and knows all the games that are played in order to extract as much money as they can from sickness in the United States of America. This hearing is also going to focus on legislation to repeal the grandfathered health plan regulation. In doing so, basic consumer protections like ending lifetime coverage limits and rescission of coverage will be undermined in employer-sponsored health insurance plans that cover 160 million people. So now we're not just talking about public plans. We're going to reach into those private plans and tell what these employers can do and offer to their consumers. It's just incredible to me that with the number of things that the Energy and Commerce Committee has to do in order to make life better for people out there who are really suffering right now under this economy. You know, you lose your job, you lose your health care many times. So people are trying to figure out how their kids are going to get health care. Our legislation said that pre-existing conditions for children will not be a reason to exclude children from health care. We said if your child has a terrible life-threatening disease that may cost a lot of money, that those lifetime caps are going to be removed. And here we sit today saying, no, 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 this is not fair to the poor insurance companies. Those poor insurance companies who have been making record profits. I think this is utterly outrageous that we should be spending our time doing that when the American people are looking to us at this moment for help. Thank you. I yield back.
Chair, thanks, gentlelady, and recognize the Vice Chairman of the Subcommittee, Dr. Burgess, for 5 minutes.
I thank the Chairman for the recognition. I do thank our panelists for being here today. Director Larson, you've been kind enough to come talk to me in my office in the time between our last hearing, and I appreciate the information that you've provided. As you'll find out today, perhaps there's a few more things that we'd like to know, and I know that you will provide them. Grace Turner, it's always good to see you again. I have to say, we talked about doing the bidding of insurance companies. Exhibit A, the Affordable Care Act. Why cannot we get the information from the White House from the 6 groups that met down there in May of 2009 that discussed how we were going to carve up things in health care? Insurance companies, to be sure, doctors, hospitals, pharma, medical device manufacturers, and the unions. So what was up with that? The President came out of that meeting and said we saved $2 trillion for health care. $2 trillion for health care. But there are no minutes. There are no emails. There's not even an envelope with a scratch on the back about what this $2 trillion represented. And we're to believe that? Now, yesterday in the Subcommittee of Oversight and Investigations, we had a big hearing on Solyndra and how Solyndra was given a loan guarantee from the Department of Energy, which had all of the appearances of being something that was a rush job and done improperly. Well, you want to talk about something that's a rush job and done improperly, it's the Affordable Care Act. Insurance companies have prospered since the Affordable Care Act passed. Go back and look at the earnings statement from the big companies from March of 2010 when this thing was passed. The insurance companies got the individual mandate. They got everything they asked for in this bill. Thank you, Democrats, for that. And now we're left to deal with the consequences of this. We're concerned about jobs. The President came and talked on the House floor about jobs last week. I'm grateful that he came with his ideas. The fact remains that unemployment stands at over 9% and doesn't appear to be budging. Now, is there a reason for this? Is partly the reason because since 2008, the government has spent $54 billion on regulatory agencies, and they're growing at 16%. The only true growth industry in this country is federal regulation, or that the government regulatory system is the 3rd largest employer in the nation, or because complying with federal rules and regulations costs $1.75 trillion per year? Is it because the Affordable Care Act and the effect that its regulations are having on our nation's employers? From overregulation to burdensome requirements to perverse incentives that will drive up health spending, this thing levies unreasonable demands on employers, manufacturers, and providers. Discourage hiring? You bet. Encourages employers to drop their insurance, apparently. Oh, yeah, and in the bargain, we're going to punish physicians and tax the industry out of America. Today, we're going to look at 2 of these requirements in some depth, but honestly, the list is much, much longer. And we're going to hear from some of those folks who are on the ground dealing with this, but I'm afraid we may be too late. This law has been proven to be unworkable and to stifle economic growth. Every day we get another announcement about another rule going into effect, and far too many are coming out as interim final rules. And what does that mean? That means we've short-circuited the public input part of that process. So if we're serious about getting America back to work, the first step should be to loosen our stranglehold imposed by this law Thank you, Mr. Chairman. And
Would you yield?
yes, I'll be happy to yield to the gentleman from Illinois.
Thank you for my colleagues. And I'm going to take this minute just to do a plug on a bill that we just dropped yesterday, which was the Medicare Common Access Card. We all know there's Medicare fraud. Part of this MLR debate is how do you stop fraud in billing? In Medicare, we know there's great fraud. What the Medicare Common Access Card, which I have a copy of one, is just using an ID card like the military does. It's a double identification system with the chip in the card and then a password. To date, in the DOD, these cards are out. 20 million of these cards have been out. There's been not a single instance of fraud. And so if we really want to make sure that the person who's supposed to receive the service is identified and properly billed for it, then I would encourage all my colleagues on both sides to look at the bill drop. On the Senate side, Senator Kirk, Wyden, and Rubio, it's like bipartisan support, and I would imagine it would have support across the spectrum from both conservatives and liberals if we want to get a national way to make sure we have secure billing. With that, thank you, Mr. Chairman.
Chair, thanks, gentlemen. Recognize the ranking member emeritus, Mr. Dingell, for 5 minutes for opening statement.
Mr. Chairman, I thank you for your courtesy, and I thank you for recognizing me. Today's hearing, Mr. Chairman, is yet another unfortunate attempt by my colleagues on the other side of the aisle to roll back the Patient's Bill of Rights, which is included in the Affordable Care Act. There's been continuing opposition to both proposals and attempts to destroy it in every possible way, including by delay and outright repeal in whole or in part. The bills before us today would strip historic reforms that protect consumers, and it is going to leave us in a situation where the things that we have done to assure and protect the rights of Americans' consuming public are stripped away in a most unfortunate way. The intent of the medical loss requirement is to ensure that consumers know that money coming out of their paychecks each month for health care is going to go for quality care, not to line the pockets of the insurance companies. This provision is going to benefit countless Americans. It is going to, according to HHS estimates, see to it that nearly 75 million people are in health plans that will be subject to new requirements, and up to 9 million Americans will be eligible for rebates next year. Costs to the government that we pay for health care will go down because of the things under attack in this committee today. The requirements that we are making are safe, effective, and achievable. The same is true here also of the grandfather health plan regulation. Preventing enforcement of this regulation allows abhorrent and false claims to be made by the other side for no reason other than political rancor. We cannot allow the public to be misled this way. Even worse, preventing the grandfathered health plan rule to move forward would be to remove a trigger for health plans to lose grandfather status if they cut benefits, increase co-payments or premiums, or make changes in annual limits. These two bills are a direct and unfortunate assault on the sick, the elderly, and the disabled, who deserve protection and assurance that they will have the care they need when they're wheeled into an emergency room, and sadly it will let insurers spend consumers' hard-earned dollars with no accountability. These things are bad from the standpoint of the public, the consuming public. They are also bad from the standpoint of the taxpayers, because the loss of these provisions is going to run up the cost of Medicare, Medicaid, government retirement plans, and it is also going to run up the cost of plans which are held by private industry for the benefit of their employees. And the situation is going to impact on ordinary citizens who buy their own insurance because they have no one to assure their protection against the abuses which the legislation before the committee would strip the consumers of protection in their enactment. I urge my colleagues to defeat this legislation, to not let it out of the committee, and to have an honest exposition of the abuses we are attacking. This committee will recall that we have worked long and hard to get a national health insurance proposal enacted into law. It isn't what any one of us would want, but it is good enough to do the job that we have need of. It is unfortunate that this legislation is also a part of an ongoing attempt by my Republican colleagues to do away with government regulation. I'm not one who is sitting here to tell you that this regulation is all good. That it would not be true. But the hard fact of the matter is what we are striking at today is not just health care, but it's a part of a pattern which will destroy regulation to protect people from bad foods, bad drugs, to protect people from fraud in the securities industry, to see to it that consumers receive protection through the Consumer Product Safety Commission, and a wide array of other programs that are necessary to protect American consumers. The idea is not to eliminate regulation, but to eliminate bad, unfortunate, and wasteful regulation rather than just striking out broadcast to destroy regulation and to strip the American public of the protections that they need for their safety, for their health, for their financial and economic well-being. I thank you for the time, Mr. Chairman.
Chair thanks the gentleman. That concludes the members' opening statements. We'll call panel 1 to the table. Our first panel is Steve Larson, Director of the Center for Consumer Information and Insurance Oversight with the Centers for Medicare and Medicaid Services. Welcome, Mr. Larson. If you can summarize your testimony, your written testimony will be made part of the record, and you have 5 minutes.
Thank you, Chairman Pitts, Ranking Member Pallone, and members of the subcommittee, and thank you for the opportunity to discuss the benefits of the medical loss ratio and grandfathering provisions of the Affordable Care Act. The ACA expands access to affordable, quality health insurance coverage to over 30 million Americans and strengthens consumer protections to ensure that individuals have coverage when they need it most. The ACA addresses many long-standing problems in the private health insurance market for both individuals and for small businesses. Since the enactment of the ACA, HHS with the Department of Labor and Treasury have already implemented many of the private insurance market reforms, including prohibiting insurance companies from imposing lifetime dollar limits on coverage, rescinding coverage absent fraud, and enabling many young people to stay on their parents' health plans up to age 26. The MLR provision in the Affordable Care Act reforms the health insurance market so that Americans receive value for their premium dollars. This provision requires that spending by health insurance companies on clinical services for members and spending on activities that improve quality for their members account for 80% of the premium dollars for the individual and small group market and 85% for the large group market. This ensures that premiums that consumers pay are not used for excessive administrative expenses. Because insurance companies whose coverage does not meet the applicable MLR standard will provide rebates to their customers, insurers are incentivized to operate efficiently, provide value pricing, and invest in activities that improve the health status of the people they cover. The provision also adds transparency to the marketplace by allowing all consumers to see how their premium dollars are being spent. Consumers will begin receiving rebates in 2012 from plans that don't meet the standard in 2011. However, we are already seeing indications that the MLR provision is causing insurance companies to more carefully evaluate their need for increases, slowing the rate of premium growth. Insurers that have not met these standards have announced to Wall Street and in many cases advised state regulators that they are now setting prices to meet these new standards. One large insurer will reportedly be dropping rates for nearly 10,000 customers in Connecticut by between 5 and 20%. The GAO also found that issuers were moderating rate increases because of this rule. Repealing this provision will be a step backward for consumers. Regarding grandfathered health plans, while the ACA requires all health plans to provide important new benefits to consumers, under the law, plans that were in existence in March of 2010 are grandfathered and exempt from some of the new requirements in the ACA. For example, grandfathered plans are not subject to provisions that require health plans to provide preventive services with no cost sharing, are not subject to the new appeals provisions, and premiums for these plans are not subject to the rate review provisions of the ACA. However, grandfathered plans still must eliminate all lifetime benefit limits, extend dependent coverage to most children under age 26, and follow other consumer protections, including the ACA, including the MLR provisions. The grandfathered plan's interim final rule is intended to preserve the ability of Americans to keep the coverage that they had when the ACA was passed. However, if the terms of that coverage are changed significantly, the plan could end up as a very different plan than the one that was in effect in March of 2010, perhaps with much higher coinsurance, deductibles, or with fewer benefits. But if this modified coverage is still considered to be grandfathered coverage, it also would not provide some of the key consumer protections that we just talked about. The grandfather rule avoids this undesirable result by balancing the interests of healthcare consumers with those of employers. It does this by giving employers the flexibility to modify existing benefits to accommodate changing conditions without the loss of grandfathered status, while also guaranteeing Americans access to important consumer protections if the coverage changes significantly. Examples of the flexibility that employers have include the ability to make changes to different types of cost-sharing provisions, such as co-pays and deductibles, to vary premiums, and to make modest changes to the levels of employer contributions. Importantly, health plans and employers have the choice of continuing the coverage that was in place on March 23rd, or making changes beyond the areas outlined in the regulation. Also, based on the feedback we've received through our process, and from formal comments in response to the interim final rule, HHS, Department of Labor, and Treasury issued an amendment to the grandfathering rule in November of 2010. The amended final rule allows employers to change carriers and keep their grandfathered status, again providing even more flexibility to businesses and insurance companies in the implementation of this provision. In conclusion, we're proud of all that we've accomplished over the last year and a half and look forward to 2014 when more Americans will have access to affordable and comprehensive health insurance plans and all of the consumer protections in the ACA will apply. Thanks for the opportunity to appear before you, and I look forward to answering your questions.
Chair, thanks, gentlemen. Now begin the questioning and recognize myself for 5 minutes for that purpose. Mr. Larson, we have heard testimony from health insurance brokers that the administration's MLR regulation is already leading to job loss and income reduction for agents. According to a National Association of Health Underwriters survey, agents are seeing income losses of 20 to 50%. Additionally, 21% of agents have downsized their business in response to the MLR regulation alone. Earlier this summer, with unemployment at a staggering 9.1%, you told us HHS would not rescind or suspend the MLR regulation under the President's executive order on regulatory review. With unemployment still at 9.1%, has the administration reconsidered its decision to continue with the medical loss ratio regulation despite massive job loss among the broker community?
We have spent a substantial amount of time looking at this impact on agents and brokers. We know, for example, that the National Association of Insurance Commissioners, that on other issues related to the MLR standard, took a pretty close look at the impact on agents and brokers of the MLR provision. Ultimately, as you may know, the NAIC declined to take further action in terms of recommendations or endorsements of changes to the MLR provision, whether it's repealing it or other modifications. As I remember the work that the NAIC did, they found that there was really a spectrum of activity, that there were certainly some issuers that had decided to lower premiums, although it wasn't always to lower commissions, excuse me. It wasn't always clear that whether that was a direct result. Some issuers, in fact, had increased. There wasn't a clear trend across all markets in all states regarding responses by issuers on the agent and broker issue. So I think it's certainly the case that in some instances insurers have limited their commissions to brokers. We're concerned about that, and we'll continue to look at it. At this point, the NAIC declined to take any action on that, and I think we have limited legal ability to do so as well.
Well, you have the ability to review regulations. Are you going to review the regs?
Well, we have been reviewing them in the context of the data that's been available to us, and we've looked at and certainly spoken with NAHU and looked at the survey. And I think the challenge is balancing the impact of major changes to the MLR standard, which will deprive a lot of consumers and businesses with rebates, with some of the impacts that agents and broker communities have expressed.
Recently, the administration announced that it would use brokers and agents to help enroll individuals in PPACA's high-risk pools. This action was taken in response to the low enrollment in the program so far. If the administration believes it is necessary to enlist the help of brokers to enroll Americans in a government program created by PPACA, why is HHS punishing the agent community and their customers in the private insurance space through the MLR rule? Shouldn't we be encouraging rather than hurting jobs in the private sector?
Well, first of all, we certainly support the role of agents and brokers in connection with the PSIP program. We were very pleased to be able to provide payments or commissions to them on the PSIP program. We certainly don't view the MLR rule as punishing agents and brokers. Frankly, it's many of the insurance companies that are taking this action. There's a very wide range in commissions that companies pay, and it's very possible that some of the companies are exploiting the MLR provision to lower agents and brokers' commissions when they may not need to be doing that. I'm not sure there's any clear data on that, but we support the role of agents and brokers both now and in 2014 in the exchanges, and we look forward to working with them to see if there's a way to get us through that period between now and then.
Now, if a small business uses a broker to assist it in finding the best health plan for its particular unique circumstances, then the commission paid to the broker will count towards the administrative cost of the plan and thus could lower the plan's medical loss ratio percentage. Yes or no?
If I understand your question, yes, commissions are considered part of the administrative expense.
If a large company has its own HR, human resource department that researches the type of health plan that it will purchase from an insurer for its employees, will the cost of the work done by the HR department be calculated in the administrative cost of the health plan? Yes or no?
No.
It seems these rules are written in a way to disadvantage small employers. It also seems as if these rules will direct people into these new exchange plans. If a small business wants to use a broker or an agent because their employees don't want to be dumped into the exchange, they should be able to, without federal rules, that tilt the playing field to government entities. My time has expired. I yield now to the ranking member for 5 minutes for questions.
Thank you, Mr. Chairman. Mr. Larson, the Republicans are portraying the discussion draft as a means for Americans who like their health coverage to keep it. And in fact, I think this legislation is much broader. The real intention, I think, is to eliminate the insurance reforms enacted by the Affordable Care Act and put insurance companies, not patients, back in control. And I just wanted to point out just a few of the consequences of this legislation becoming law. One is over 1.2 million young adults would lose their insurance coverage because plans would no longer be required to cover them until age 26. Over 165 million Americans with private insurance coverage would be vulnerable, again, to having lifetime limits placed on how much insurance companies will spend on their health care. 15.9 million people in the U.S. would be at risk of losing their insurance because rescissions would once again be legal. And 41 million Americans would lose guaranteed coverage for preventive services like mammograms and flu shots without cost sharing. Up to 43 million people in small business health plans will lose their medical loss ratio and rate review protections, which would allow insurers to charge them high prices for low-value plans. Now, Mr. Larson, would it be accurate to say that this legislation is yet another attempt and way to repeal health reform?
The discussion draft that I've seen certainly would do more than modify the grandfathering rule, but in fact repeals the applicability of all the protections that you just enumerated from any of the plans that were in place at that time.
And does the Republican legislation allow patients to keep their insurance if they like it, as claimed by Republicans, or are insurers really in charge, allowed to cut benefits, increase cost sharing, and make other changes?
Yeah, it doesn't, and that's the whole point of the rule. The rule provides employers some flexibility to make changes, but in the absence of the rule, employers and health plans could rewrite the entire plan, cut out benefits, remove protections. The plan would look very different. It would not look like the same coverage.
Now, Republicans have repeatedly claimed that the grandfathering rule issued by HHS will result in tens of millions of people losing their health care. Is it accurate to say, as some are, that the grandfathering rule will result in people with employer-sponsored coverage being denied or losing their health insurance coverage because of HHS or because of the Affordable Care Act?
Yeah, because the provisions that now apply to grandfathered plans include options for people to get better coverage. So if you're removing that, you're going to have people that don't have coverage that would have had it if the bill weren't in place.
And so where would Republicans get the idea that tens of millions of people are losing their health care? I mean, where is this coming from?
I don't know exactly where that is coming from.
Okay. I mean, it just appears to me it's another case where the Republicans are inventing problems allegedly caused by the Affordable Care Act. And even if plans do lose grandfather status, that doesn't mean a person loses their health insurance. In fact, they gain some consumer protections like rights to external appeals and coverage of preventative services. And in any case, these requirements will not be prohibitive for employer plans because they usually already meet the rules. One employer benefits consultant notes, and I quote, that large companies realize that they already comply with many of the requirements of non-grandfathered plans, so the changes they'll need to make aren't likely to add a significant cost or administrative burden. To me, this is just a lot of nonsense. It's just another way to repeal patient protections, and everything that the Republicans are saying is going to happen. In fact, it's just the opposite. Let me just issue one more thing. I've got another minute here. Under the Republican legislation, grandfathered health plans would not have to report or openly justify premium increases. Have you seen an impact from rate review on premiums in any states in which it's been implemented so far? And is rate review going to be an impossibly onerous burden for insurance companies to meet?
Well, like the MLR provision, we know that the rate review provisions are having impacts now. They're beneficial impacts. They're lowering rates. We know that rate review, the process works to lower rates in states, and I think we've cited in other hearings in our materials where commissioners have looked at rates and concluded that there were improper assumptions or excessive requests that have been scaled back and saved people, millions of dollars of premiums. So that's a very important provision.
I mean, it just seems to me that, the patient protections, the regulations on insurance companies that are consumer protections, they're all working. They're all having a very positive impact. There's absolutely no reason not to let the insurance companies continue down that path to protect the consumer. It's not that onerous. And now we're just going to say, let's throw it all out and let the insurance companies do whatever they please, which makes no sense. Thank you, Mr. Chairman.
Chair, thanks to gentlemen, and recognize the Vice Chairman of the committee, Dr. Burgess, for 5 minutes for questions.
Thank you, Mr. Chairman. And again, Dr. Larson, let me thank you for your willingness to provide our office with information. We've gotten some things answered. There's some things that are still outstanding, and I suspect there'll be some new questions that come up as a result of our interaction today. And I'd just like to have your commitment to continue to work together to get answers to those questions.
Yes, sir. I know that we provided an initial response to you since our last meeting, and we're working quickly to get the rest of those to you.
Let me ask you a quick yes or no question. States have rate review authority, and they had that prior to the passage of the Affordable Care Act. Is that correct?
Some did, some didn't.
Now, in response to a question that Mr. Pallone asked, you said you didn't know where the figures came from about people who would lose their plans under grandfather status. So June 17, 2010, Department of Health and Human Services issued an interim final rule imposing additional restrictions that health plans must comply with in order to protect their grandfathered status. The administration issued an amendment to the interim final rule 17 November 2010. By the administration's own estimates, 49 to 80% of the small employer plans, 34 to 64% of large employer plans, and 40 to 67% of individual insurance coverage will not be grandfathered by the end of 2013. So that's from which those figures come. And we will be glad to provide you the places for those citations so you can familiarize.
Well, perhaps I misunderstood. I thought that the question was there a claim that people were going to lose their coverage? And the answer is no. If those statistics relate to the projected transition.
But remember, the big selling point on the Affordable Care Act was if you like what you have, you can keep it.
Sure.
And if people like what they have, they may not be able to keep it. And I think that's a fair statement. Is that not right? Yes, is the answer to the question. Let's move on. Are you familiar with the Texas Benefit Pool?
Say that again.
The Texas Benefit Pool, it's not the high-risk pool, but this is a benefit pool for relatively small jurisdictions, like small towns, and there are a number of small towns in Texas, to be able to pool together to purchase health insurance for their municipal employees that otherwise, and these are frequently cities that have significantly less than 50 employees under their jurisdiction. So 40,000 beneficiaries in 750 different political subdivisions, and 90% of these members have 50 or fewer employees. Under the Affordable Care Act as currently written, they will go out of business. They cannot be a grandfathered plan. They cannot survive as a health plan in the exchanges because of the tight definitions. So it looks like they've got nowhere to go. And this is a solution that the state of Texas created to a problem well over 30 years ago. It's worked, and it's providing lower cost health care today, but it's going to end up costing the federal government more because you will need higher subsidies for low-income workers in higher-priced plans. So is there how do we say we're promoting state flexibility when in my state it'll force a lower-cost alternative for municipal employees to go out of business and drive those employees into a one-size-fits-all exchange structure, which will increase federal spending even more?
Well, I have to confess I'm not familiar with the entity that you just referred to. We'd be happy to work with you to determine, how it fits into the exchange structure in 2014.
All right. We'll get you some more information on that. And I've got a number of other things, and obviously, clearly, I'm going to run out of time. As you know, I have been fascinated by your center or office or whatever we're calling it since I first learned of it a little over a year ago. And what began as the Office of Consumer Information and Insurance Oversight last summer is now the Center for Consumer Information and Insurance Oversight, and it is now under the direction of the Center for Medicare and Medicaid Services and not a standalone agency within the agency. I basically given a recapitulation of your brief history correctly?
Yes.
But also nowhere in here is your agency or center authorized. It was not mentioned specifically in statute in the Affordable Care Act. So it was a mystery to many of us when we first learned about it in August of last year that you were up and running and office space off the hill and hiring employees. And I remember talking to your predecessor about, well, why in the world could you not, surely these are functions that are already being performed at HHS. Why not just be, you're duplicating abilities? And I was informed that that's not the case because for the first time, the federal government is going to regulate the entire private insurance market in the country, which historically has been a function of the states. Is that correct?
The original office, OSIO, yes, was set up to implement the new provisions relating to the private health insurance market.
And we have a new agency or a new office or center. Not authorized under statute. You've spent now, according to figures you provided me through the end of August, almost $3 billion, $3.2 billion in implementation funds, correct?
Well, much of that, as you know, I think you know, are the reimbursements under various programs that we.
It's just fascinating that this could occur.
We haven't spent that money on
and it not
the
be in
operations
statute,
of society.
and Congress not be aware of it. I mean, so I welcome your presence here today. I think it's good we're finally having this dialogue and this oversight, but it troubles me that it occurred the way it did. It was seemingly something that was be cast under the radar screen. And thank you, Mr. Chairman, for your indulgence. I'll yield back.
Chair, thanks, gentlemen, and recognize the Ranking Member Emeritus, Mr. Dingell, for 5 minutes for questions.
Mr. Chairman, I thank you for your courtesy. Director Larson, yes or no questions. Is it true that prior to the Affordable Care Act, MLR standards and or reporting requirements varied widely from state to state? Yes or no?
True.
Is it also true that 34 states prior to ACA had a minimum MLR standard or reporting requirements for certain markets? Yes or no?
I think that's right, yes.
As you know, ACA sets a minimum federal MLR standard. As a former state insurance commissioner, do you believe that this will simplify regulatory compliance for insurance companies? Yes or no?
Yes.
Further, do you believe that minimum MLR requirements will encourage greater transparency and understanding in insurance spending for consumers? Yes or no?
Yes, I do.
Under the Affordable Care Act, the National Association of Insurance Commissioners was tasked with coming up with definitions and calculations for MLR requirements. Were the recommendations from the National Association of Insurance Commission taken into consideration prior to the interim final vote? Yes or no?
Yes, in fact, we adopted them all.
As a matter of fact, you adopted them all. That's right, isn't it?
Yes, sir.
Is it correct that the NAIC recommendations were unanimously approved by the insurance commissioners from all 50 states and the District of Columbia?
Yes, that's correct.
So you had vast unanimity on this matter, did you not? Now, how do you separately consult? Now, did you separately consult with the states, the public, and other stakeholders prior to issuing the rule? Yes or no?
We accepted the public input process that the NAIC conducted, and then we have since taken comments and plan to look at further modifications to the MLR standard.
Now, one item that's gotten much attention recently is the ability of the states to apply for an adjustment under MLR requirements. The Affordable Care Act allows the Secretary to adjust the MLR standard for the individual market in a state if it is found that the standard may destabilize the individual market. Is that correct?
Yes.
And have you had applications for this kind of waiver, and have you granted such kinds of waiver?
We've had a number of applications. I think that we've granted 5 of the ones that we've reviewed so far.
Now, is this adjustment meant to help the transition the state and the insurance plans will have to make to comply with the new federal minimum MLR standards?
Yes, sir. That's exactly what it does, a smooth.
How many states have requested an adjustment so far?
I think it's about 13.
Of this number, how many states have received adjustments?
5 of the ones, but we haven't finished reviewing many of them. Their applications are not complete yet from the states.
Has anybody been turned down?
We have, yes, 2 states.
In whole or in part?
In whole.
In whole. This temporary adjustment then maintains the intent of MLR requirements, which is to ensure that the majority of premium dollars are spent on medical claims and activities to improve health quality. Is that right or wrong?
Correct.
As a former insurance commissioner, do you believe that the MLR requirement will help the American consumer get more value out of their health plans? Yes or no?
Yes.
Now, under the MLR requirement, we're already starting to see insurance companies either slow or decrease the growth in premiums. Is that right?
Yes.
Do you believe that the repealing of the MLR requirements will harm or hamper or impede this progress? Yes?
It's a step backward, yes.
All right. Now, let's take a little look. Some of the things which will be adversely affected here that we're concerned with are things like insurance for young adults to 26, prohibition of rescission of insurance, prohibition of annual and lifetime limits, prohibition on pre-existing condition discrimination. I want you to note particularly that one. No cost sharing for preventive benefits, patient's choice of providers, protecting small businesses, giving them new rights, protecting patients from medical bankruptcy, and right to appeal from insurance company denials. All of those new rights will be adversely affected by this legislation. Is that correct?
Yes.
And the rights will be taken away from the consumers. Is that right? Thank you, Mr. Chairman. Bad piece of legislation. I hope everybody's noting it.
Chair thanks the gentleman. Recognizes the gentleman from New Jersey, Mr. Lance, for 5 minutes for questions.
Thank you, Mr. Chairman. Good afternoon. It's very good to be with you. There obviously remains significant interest in Congress about anti-fraud efforts in Medicare and Medicaid on a bipartisan basis. In fact, you stated that fighting fraud in Medicare was a key goal of the administration when you came before the committee in May, and we all agree with you on that. As I understand the MLR regulation, there is an exclusion of health plan investments and initiatives to prevent fraud from those activities that improve health care quality. It seems to me that this creates a perverse incentive to tackle fraud on the pay and chase side rather than the prevention side. And I believe CMS is stepping away from the pay and chase model. Could you give us your views on why we may be choosing to penalize measures to combat fraud and abuse in the MLR rule?
So the way that the MLR rule treats fraud is it allows certain fraud recovery expenses to be included, but not all of them. And that was essentially the middle ground that the NAIC reached when they looked at this issue and balanced the desire to, encourage companies to invest in fraud prevention and recovery versus the statutory language. I will say, though, that I don't think that we agree with the conclusion that this creates a disincentive for investment in fraud, because to the extent that insurers invest in fraud prevention and fraud recovery and lower their underlying expenses, they're going to be in a position to lower their premiums and have a competitive advantage compared to other companies that don't make those types of investments. So even though it's not fully recoverable in the MLR formula, we don't agree that that creates a disincentive for plans to engage in what activities that they should do, and that's helpful for their efficiency as well.
Why not go all the way and permit it and not have a middle ground?
Well, again, the statutory language that we're dealing with talks about two categories. Categories related to clinical services, like paying doctors and hospitals.
Yes, sir.
And then quality improving activities. And again, I think the NAIC and we agreed came to kind of a middle ground on this issue, but thought that it would be really stretching the envelope to include a wider range of expenditures relating to fraud prevention.
Thank you. I obviously respectfully disagree, and I hope that you might examine that again. HHS has issued interim final rules implementing PPACA without first issuing proposed rules and receiving comment. From my perspective, HHS is acting on an ad hoc basis with no clear standards. What is your protocol for deciding when HHS will issue a rule on an interim final rule without first issuing a proposed rule?
Well, in the case of implementing the ACA, there were a number of interim final rules, or IFRs, that we issued in June right after the bill passed.
Yes,
and those were largely a function of the pressing time frame that was facing us to get regulations in place so that businesses and individuals had guidance as to how the law would be implemented. In areas where we've had a longer lead time to implement the law, we have done proposed rulemaking. So, for example, on the rate review reg, we did a proposed rule, and then we finalized that rule recently. So it's largely, in the case of ACA, been a function of meeting the statutory deadlines. And, of course, after we issue the IFR, we always take comments, and in some cases, like the grandfathering reg, we went back and have amended.
When will you be replacing the interim final rules with final rules, such as the grandfathering and
right.
MLR
So we
rule?
continue to evaluate the comments that we've gotten in. I can't provide you with a specific timeline for that at this point, but we continually evaluate the status of the interim rules to determine.
Do you think it might be by the end of the year, Mr. Larson?
If I could get back to you on that.
Certainly through the distinguished chairman. Thank you, Mr. Chairman. I yield back the balance of my time.
Chair thanks the gentleman and recognize the gentleman from Louisiana, Dr. Cassidy, for 5 minutes for questions.
Hello, Mr. Larson. Now, just to be clear, if somebody has a high deductible health plan with an HSA, the contribution to the HSA is not included so they pay out $2,000 out of their HSA. That is not included in terms of the claims payment history of the insurance company, correct?
I think that's right.
That's my understanding. Now, it seems like there is a clear prejudice here because the insurance company has fixed cost. They have rent, they have utilities, they have whatever. So that the high deductible health care plan, 95% of people whom have these have less than $5,000 per annum expenses, and their deductible may be $5K.
Right.
The insurance company has, as an absolute amount, less dollars because of the 15% MLR, correct? If you will, this is a clear prejudice against the plan which encourages the person to be most cost aware and which studies show gives the nice balance of the customer, if you will, the patient, looking for value. Is that easily acknowledged?
I know that's one of the perceived benefits, yes.
So that's the perceived benefit of the plan?
Yes.
And studies would show that it's true. Now, that said, this MLR is clearly prejudiced against such plans. They have fewer absolute dollars with which to pay their administrative fixed cost relative to a Gold Star plan, which, my gosh, if you charge $10,000 for a policy versus $2,000, in absolute dollars, there's a lot less. Fair statement?
Right.
So why would we have a policy which is prejudicing against the purchase or the delivery of a plan which studies show give you a more cost-effective purchase of health insurance?
It's a question we can go back. To be honest with you, the issue about the applicability of this to the higher deductible plans hasn't come on my radar screen, so I'd be happy to go back and look at that.
I have to say that surprises me since we see the uptake of HSAs with high deductible health care plans is increasing dramatically. And again, this is a clear prejudice towards higher cost plans because the higher cost plans at a 15% MLR has more absolute dollars for the insurance company to play with. Is that, again, that's not disputable, is it?
So we can go back and look at that. As I said, we have, there's a number of issues that are kind of front and center on MLR, and there's some provisions we may have to modify before the end of the year, so I'd be happy to look at that.
Yeah, when you say look at, I just don't know what that means. Does that mean that you can see that there's a problem here or that, well, we'll look at it? Do you see what I'm saying?
Yeah, I think it means that I'd like to, sit down and get a better understanding of how the MLR provision applies. Again, and it may just be me, we haven't, heard a lot about this. At least I haven't. Doesn't mean, I confess it doesn't mean that my staff has not. So look at it means understand it and see if we need to respond to it.
The second thing is, so you're at least open to having a different set of rules for high deductible health care plans?
Pardon me?
Are you open, or is it possible to have a different set of rules for catastrophic plans?
I don't know whether the statute would allow that or not. So it's,
If the statute does not, would you think it would be a reasonable thing to correct that? Pass another law, perhaps?
I hesitate to say without having a better sense of what I'm talking about.
Okay, that's a fair statement. The other thing that disturbs me is that the pattern of usage by the person with the HSA will greatly influence how this applies. If you have a group of people each with $2,000 HSAs and each uses $2,000, you never enter into a claim. But if one person has $10,000 and everybody else has zero, you got 5 people in the group, everybody else has 0 but one has 10,000, then clearly there's going to be claims paid.
Right.
You're more likely to be able to hit the MLR requirement, even though the claims history for the group is no different. Fair statement?
Sounds like it.
Yeah, so I have to admit that this kind of bill, which everybody is endorsing over there, is sacrosanct, gives me great pause, just as I think about it. I have a little bit of time left. My insurance companies, clearly a criticism of our system is that it is a sickness treatment system, not a wellness promoting system. There's an insurance company back home, Baton Rouge, Louisiana, which goes into a small employer and institutes wellness programs. And in so doing, they actually decrease utilization. They have outcomes data that shows this. But apparently this would be included in their MLR. They say they're going to have to eliminate the wellness program because it will blow, granted, claims history is down, which in of itself decreases their absolute dollars, but a portion of their administrative costs is getting the folks over 50 to take an aspirin a day and get their... So again, this seems like we are prejudicing against these...
Well, I guess I have to confess that I don't understand, because that activity, at least that you're describing, would sound like it would be a quality improving activity. We lay out the categories in the statute actually lays out the categories for improving healthcare outcomes, lowering hospital readmissions, prevention, wellness. Those are all part of the permissible types of expenses. So I'm not clear why, in the situation you're describing, there's a disincentive to do that. Sounds like it would be the opposite.
So I'm out of time, so let me pursue that and we'll get back to you.
Okay.
Thank you.
Chair, thanks to the gentleman. Recognize the gentleman from Georgia, Dr. Gengry, for 5 minutes of question.
Mr. Chairman, thank you. I'm going to shift gears just a little bit. I want to talk about the Class Act. Quote an article that ran in the Atlanta Journal-Constitution yesterday. Even as leading Democrats offered assurances to the contrary, government experts repeatedly warned that a new long-term care insurance plan could go belly up, saddling taxpayers with another unfunded benefit program, according to emails disclosed by congressional investigators. Ends the quote. Mr. Larson, that quote was based on a joint report produced in part by Energy and Commerce Committee Republicans that sheds a bright light on the suspicious inner workings of congressional Democrats and White House as they pushed for Obamacare. The report finds that after repeated warnings from CMS chief actuary and others about the insolvency of the class program, HHS and Senate Democrats effectively cut the actuary out of the process and turned to CBO to give them the numbers they needed. Only those numbers were wrong. 18 months after CBO pronounced the Class Act solvent, Secretary Sebelius finally admitted to the world what we all knew, that the Class Act was in fact insolvent. As of today, CBO has failed to make public the economic model cited in the report that deemed this program solvent. Even worse, CBO staff now says they do not have the capacity to analyze the Class Act's long-term solvency. Mr. Larson, I believe that the economic modeling used to sell PPACA, Patient Protection Affordable Care Act, to the American people needs to be thoroughly reviewed from top to bottom. Further, I would once again call on this Congress to pass H.R. 1173. That's a simple bill that my good friend Dr. Charles Bustani from Louisiana and I have introduced to repeal the Class Act. The Class Act is just another example of how bad policy can threaten the financial health of this great nation. What say you, Director Larson?
Well, I will have to say that I will take your comments back to HHS. The Class Act does not fall under the area that I have responsibility for, and I have to confess I have not kept up with the current situation with the Class Act, and so I'd be happy to share your concerns.
Well,
but I can't respond to them today.
Yeah, well, fair enough, and I do appreciate the fact that you will take that back and continue to discuss it, because clearly it's insolvent and it's a real cost driver. Let me follow up on Dr. Burgess' question for a minute. The President promised the American people that if you are among the hundreds of millions of Americans who already have health insurance through your job, Medicare, Medicaid, or the VA, nothing in this plan will require you or your employer to change the coverage or the doctor you have. Let me repeat, nothing in our plan requires you to change what you have. Now, that's a pretty much a direct quote from the President. Do you agree with the President that nothing in the Patient Protection and Affordable Care Act will make the hundreds of millions of Americans who already have health insurance through their job to change the insurance that they have today?
That's the point of the grandfathering provision, and I think that's what our regulation permits, which is for people to continue to keep the coverage that they have.
Well, you know, let me express a concern, Mr. Larson, that I have, and maybe turn it into a question. And it's not just me, and as a physician member of the committee and of the Congress, having too many 26 years, 31 years clinical practice of medicine, but you know, it just seems to me that the way this bill was set up, with expansion of Medicaid up to 133% of the federal poverty level. So you force more and more of the uninsured onto the states that have to balance their budgets and cost them an additional billions of dollars. You, at the same time, not you, but the bill, even though you're talking about the grandfathered provision and all that really concerns us, as you've heard from committee members on this side of the aisle and MLR, and why we feel like that was just another reason why so many of these employers that cover American workers are going to drop their health coverage unless, of course, it's provided through a union contract. So you basically force a bigger volume of people onto the exchanges, and you avoid a lot of the premium support because you push the nearly poor into Medicaid, and therefore you make this program work by virtue of volume. Health insurers like that, of course, and requiring individuals to purchase health insurance even if they don't want it is all part of that scheme. And you ultimately end up with Medicare from cradle to grave. And that's a legitimate concern. I know I've run out of time, but if the chairman will indulge me, what say you in regard to those concerns?
Well, you covered a lot of ground, but a couple of comments. One, the ACA expands coverage through a number of different mechanisms, certainly through a Medicaid expansion, which, by the way, the newly eligibles are covered at 100% match through, I think,
for 2 years, yes.
For, I think, longer than that. And then, yeah, we rely on private market solutions in order to expand coverage for those that are not eligible for Medicaid. There is a premium subsidy for folks between the 100 and 400% of poverty, but those policies are provided in the exchanges through private issuers, and that I think all the studies show that is going to result in a significant expansion of coverage for non-Medicaid individuals as well. So.
Mr. Chairman, thank you, and Mr. Larson, thank you.
Sure. Thanks, the gentleman, and recognize the ranking member for issue of question.
Mr. Chairman, I would just ask unanimous consent to enter 4 letters into the record, a group letter from nearly 50 organizations, HIV Healthcare Access Working Group letter, American Diabetes Association letter, and the Main Street Alliance letter. And, you know, these are in opposition to the draft, and I believe you have them.
We have them without objection, so ordered.
Thank you.
The chair now recognizes the gentlelady from Illinois, Ms. Schukowski, for 5 minutes for questions.
Thank you, Mr. Chairman. I just wanted to correct one item that I think was mistaken that was mentioned in questioning. Between July of 2010 and July of 2011, the number of insurance agents and brokers actually went up by 5,500 people. So we were hearing about the growing unemployment. In fact, that number has actually increased. This is according to the Insurance Information Institute. So we're seeing about a 0.9% increase in employment, and you know, given the facts today, not bad, not great, but not bad, and going in the right direction. In 2010, Mr. Larson, United Health, WellPoint, Humana, Cigna, and Aetna made combined profits of $11.7 billion by reducing the share of premiums that's being spent on the shrinking membership in private health plans. Through the recession and its aftermath, from 2008 to 2010, their combined profits increased 51%. In 2009, the total private membership to these 5 companies was reduced by 2.7 million people, and another 839,000 in 2010. That was just 2009. Then 2010, another 839,000 at a time when 50.7 million people were already uninsured. So profits went up. The number of people that they actually served went down. Despite this decrease in membership, in 2010, the 5 insurers collected $7.7 billion more in premiums than in 2009. However, the medical loss ratio for 4 of the 5 companies decreased from 2009 to 2010. So clearly the money generated by rising premiums was not being used for medical or patient care, my point. Health insurers are making enormous profits at the expense of their consumers, and this is not an isolated example. Insurers claim that these profits are not large relative to the size of their business, but what I see is nearly $12 billion in profits, while hard-working families have been asked to pay more and more in premiums. So where does profit fit into the medical loss ratio, and does a lower medical loss ratio allow insurers to still make a decent profit?
The answer is yes, that they do still. These standards still clearly allow issuers, insurance companies, to make a very fair, reasonable rate of return and profit. The profit is part of the broad administrative expense, so everything that isn't paying doctors' bills or investing in quality is part of the administrative expense. So it's profits, salaries, commissions, overhead, rent, all of that is part of the administrative expense.
And when insurance companies talk about their profits, they've already subtracted those other things, have they not?
Well, I think they're part of the other mix. I guess the point I'm trying to make is that there's a lot of latitude for the insurers, say in the individual and small group market. They still have 20% of the premiums to devote to all of the things that I just enumerated, including profits. And so they have the flexibility to modify their business model to lower rates in order to hit the MLR standard. And it still leaves a lot of room for them to make reasonable profits.
So what I've taken from this panel is that a number of insurance companies actually are meeting this medical loss ratio standard that you've set. Some have actually lowered premiums, making it easier for consumers. That the number of insurance agents and brokers, which I just learned, has actually gone up, and that insurance companies are doing great, and that they can well afford to meet this sensible and modest standard. That's my summary. Am I wrong on any of those points?
I agree.
Thank you. I yield back.
Chair thanks the gentlelady and recognizes the gentleman from Illinois, Mr. Shimkus, for 5 minutes.
Thank you, Mr. Chairman, and welcome. Mr. Larson, sorry about being in and out of the hearing room. They brought meetings down into the side room, so I've kind of been in the area, but I hope I don't ask questions that have already been asked. I was going to follow up on what the chairman initially asked, but he stole my great question, so I'll move to a couple other things. And some of this is kind of like Dr. Gingrey and just maybe messages to send back to HHS and like, this is a great committee, especially on our side. We've got practitioners, so I like sitting in. I'm not one. I'm a receiver of their benefits, but you got Dr. Cassidy, you got Dr. Burgess, you got Dr. Gingrey, and no one really debates that they're compassion and concern for the healthcare system because that's their livelihood. So I do enjoy sitting in and listening to them as they try to make sense of how we can best care for our citizens. Is there any internal memos going around HHS as to different agencies as far as if the Select Joint Committee does not meet their goal? The defense budget is number one in the discretionary budget. Number two in the biggest cost of the national government, is HHS. Are there any, have you received word as to your office as if there is a sequestration, what that might do? And is there some analysis going on as to how that may affect the rollout of the Patient Protection Act?
I suspect there are, but I'm really focused on the day-to-day implementation of the provisions, like the things that we're talking about today. So
they haven't talked to you about that yet?
They have not come talk to me about it.
Okay. And obviously that's part of my concern. I did support the legislation, but my really concern was for the committee that the savings is on provider payments. I mean, hospital payments, right. Physician payments. As we know, Medicare pays 70 cents on a dollar. Medicaid spends 60 cents on a dollar. I have great concerns. The other direction I'd like to go is on the medical loss ratio. We are not a good arbiter on fighting waste, fraud, and abuse. And do you not believe there's any credible support that the ability of the insurance companies to fight waste, fraud, and abuse should be part of the medical loss ratio? Obviously, that's why we passed this legislation on the Medicare card.
Well,
because we are terrible. We are terrible.
Yeah, a component of it is up to they can include the amount of expenditures of recovery based on what they recover. And again, that was the balancing that the NAIC achieved when they looked at this issue. They spent a lot of time looking at this, getting input from different groups. We adopted that balance. So there is a component there, but I previously testified we don't agree with the idea that not including everything is a disincentive to those expenditures. We just don't.
Yeah, let me go quickly. I'm going to run out of time. And to my friend from Illinois, I mean, I just had the insurance and financial brokers in yesterday. They weren't there telling me the times are good. They were in the office telling me times are bad, and part of it is because of this piece of legislation that's now law of the land. And finally, a question on we did delegate policy-making responsibilities to the National Association of Insurance Commissioners, and but HHS said the association followed a thorough and transparent process in which the views of regulators and stakeholders were discussed, analyzed, addressed, and documented in numerous open forums. Were HHS comments documented and posted on the Internet with everyone else's?
You mean the comments that we provided to NAIC during their process?
Right.
Well, I don't know that we actually provided kind of formal. We monitored their process, so we were very much aware of what they were doing.
Yeah. Did you attempt to influence their work product in any way?
I don't recall providing written comments to them on any of their issues. So we would listen into their phone calls, but that was largely a delegation to the NAIC. And we would talk to their staff from time to time.
And I'll finish with this. In October 2010, at the NAIC meeting, over a dozen commissioners proposed that NAIC's official MLR submission to HHS remove agent commissions from the MLR calculation. The votes were there to pass an amendment, but it was never called. I understand you were in that room that day. Could you tell us exactly what discussions you and anyone else had at HHS had with the NAIC members and staff regarding agent commissions and MLR at the meeting on October 2010?
Yeah, we went down as members of our staff have been to all the NAIC meetings. They're a close partner of ours in the process, so we were there to observe the process. We were not there to lobby.
So your testimony would be you didn't influence it?
No.
Okay, thank you.
Chair, thanks, gentlemen. Recognize the gentleman from Kentucky, Mr. Guthrie, for 5 minutes for questions.
Thank you, Mr. Larson, for coming. I do appreciate it. I just want to kind of go a little different path about the rebates and how the rebates are sent back to the employers. And my line of question with this, the other day I was back in our work period, and everywhere we go, it seems like we walk in. And I know the president says there's a headwind on the economy, but I'm telling you, walk in. I went to one of the smallest banks in Kentucky, smallest in my district for sure. He said, let me introduce you to my new employee. That's our new compliance officer. He doesn't make any loans, doesn't create anything. All he does is make sure we comply with the new law that came down. And so in this, we do things here in Washington. They sound simple. For instance, we're going to rebate back to the employer if the MLR is breached. And so then I can see myself walking into a company, want to talk about how we're going to compete with China, Brazil, whatever, and say, let me talk to my HR person that just got back from a briefing, and asking questions like, if the breach moves forward in an employer-sponsored plan, is it correct that the plan can either pay the employer or the employee? They can pay either employer or employee, correct?
They can do what, sir?
If the health insurance company, if they breach the MLR, can rebate. The rebate can go to the employer or employee.
Well, right. This is a tricky issue. What we said in the reg, and we are looking at possibly changing this.
But if it goes to the employee, then the employee is responsible for writing a check back to the employer for the percentage that they don't
The scenario is, so the employee contributes to the health care
like 20%,
premium.
right.
So you've got basically two people paying combined the premium to the company, and so if there's a rebate, we have to figure out how does the rebate get back to the people that paid it. And we understand that concern. In fact, in the proposed rule, we proposed that the insurance company have the obligation to make sure that everyone got the right money. And
so then the employer is going to have to send to the insurance company.
Yeah, and we said you could enter into an agreement with an employer to kind of discharge your obligation. The insurance companies have said that's tricky. We're not sure how that's going to work.
Yeah, that's the problem. They're out here trying to make it work when it sounds simple. But then if the money comes back, because I'm going to give a couple minutes. So the money comes back to the employer or the employee. It's now taxable income, correct?
That I'm not sure about.
I think it would have to be because your premium dollars are pre-tax income, so you'd have to pay payroll. So you have to go back and fix the payroll taxes, correct? They would have, if that's true. That's not your area of expertise.
Assume that's true.
Assuming that's true. Assuming that's also true, then the end of the year, the employer is going to have to update W-2 forms and redistribute them out to all their employees. So, I mean, it sounds simple, but, I mean, we hear it everywhere. Everything that's going on in this town, you go to an employer in Kentucky, they haven't had this one yet because it's not implemented, but that's what they're saying here. It's reminiscent of the 1099s, which created an uproar. And that's the problem that we're seeing is we can design something that sounds simple on paper, and then all of a sudden, who does the check go to? That's what they'll be asking us. Do I have to take out payroll taxes? If I have to pay payroll taxes, I have to update the W-2 forms. Does the income go on this year or does it go on next year?
Well, we will work with folks as we're in the middle of discussion now to try and figure out a way to make it work. We don't want to lose sight of the purpose, which is if folks are in the position to get a rebate, it means that they overpaid.
Well, I agree.
They're entitled to get money back. So,
and then you got to say, do I have to do amended tax reforms now? Right. I mean, it just continues to pile out.
So we want to keep it simple, but we don't want to lose sight of the fact that we want them to get the value for their premium dollar. And if they overpaid, we want to make sure that they get the money back in their pocket.
We do hope it's simple. That's what it needs to be, simple. And I'm going to yield to my friend from Louisiana the rest of mine.
Okay.
Thank you. Mr. Larson, briefly reflecting on your remarks, I'm struck that y'all have not considered HSAs. And so I just pulled some statistics. I think I've heard in the past that all new hires in GM's executive corps have HSAs. I just pulled up something in Lynchburg, Virginia, all the county all has HSAs. I then just pulled up something which from American Health Insurance Plans, which speaks about how 11.4 million Americans now have HSAs, which increased 14% in the last year. 26% of the growth in the large group, but 15% in the individual market. I got to ask, man, why have you not considered HSAs? Because it seems like that is the emerging market.
Yeah. Well, when you say consider it, meaning consider it as a problem in the context of the medical loss ratio regulation.
Correct.
And all I'm saying to you is that has not come on our radar screen, at least mine, maybe other folks in the agency, as an issue that we need to address in terms of the imbalance.
Now, to me, that reflects either, and no offense, but since to me it just seems so apparent that if you have a plan which is more parsimonious, or at least in terms of how much do I have to pay for it, not as much, and this in absolute dollars, which we're on opposite sides of the issue on this bill, but we can both agree.
Yeah. I'm not sure the NAIC flagged this for us either, so I'm not at all adverse to looking at it. We've got a lot to do to implement this law, and when issues are brought to our attention, we take them seriously and we'll look at it. And, we've looked at other issues. We amended the grandfathering rule based on comments we got. We're looking at possible other tweaks to the MLR rule that we've announced previously. I'm not making news here, how we're going to deal with the mini-meds going forward and things like that. So we'll certainly put this on the list.
Okay, thank you.
Okay, the Chair thanks the gentleman. That concludes the questioning for Mr. Larson. Thank you very much, Mr. Larson, for your testimony, your willingness to answer questions and to work with us, consider the issues raised. We'll call now panel 2, and our second panel consists of 5 witnesses. Our first witness is Mr. Edmund Hasselmeyer, Senior Research Fellow in Health Policy at the Heritage Foundation. Next is Ms. Grace Marie Turner, the President of the Galen Institute. Our third witness is Ms. Janice Troutwine, who is the CEO of the National Association of Health Underwriters. Our fourth witness is Mr. Wendell Potter, Senior Analyst at the Center for Public Integrity. And finally, Ms. Lynn Quincy, Senior Policy Analyst for the Consumers Union. So we'll begin at my left and go down the line. Mr. Hasselmeyer, you may begin your testimony. We ask you to summarize your written testimony in 5 minutes, and your written testimony will be made a matter of the record.
Thank you, Mr. Chairman, members of the committee, for inviting me to testify today. A few points that I will make out of my written testimony. I have pointed out in that testimony that there are a number of problems, some of which have already been discussed with this the minimum loss ratio regulations. The discussion has already addressed in the previous panel what I see as one of the biggest problems, which is the disincentive for insurers to spend money on preventing fraud and abuse. Mr. Larson pointed out that there are some provisions that allow insurers to get some credit for that. That is true. I cover that in my testimony. The problem that I would point out here is really one of statute. It is not a fault of the NAIC or Mr. Larson's office. The problem is that the statute was badly written, and this was not accounted for when they wrote the statute. It's one of many problems. What Mr. Cassidy was pointing out about HSAs is another problem, and the problem with rebates and how they're paid is another problem. These are things that Congress simply did not consider when they drafted the statute, and in my reading of the statute, I'm afraid that NAIC and Mr. Larson and HHS really have limited ability, because of the constraints of the statute, to actually fix what are very real problems. And that is why, Mr. Chairman, I'm encouraged that you're having a hearing on this, because it really is Congress that needs to fix the problems that they've created here. Mr. Larson made the observation, and it is a correct one in my view, and I didn't touch on it in my testimony, so I'd like to expand on it for a minute, that even though the MLR provisions disincentivize insurers to pay attention to fraud and abuse, he doesn't think that that will be a problem, because an insurer that neglects those activities will result in having higher claims costs and higher premiums, and thus be competitively disadvantaged. And I would say that he's economically correct if you assume, and this is the big if, that you still have a robust competitive insurance market. Unfortunately, as I outlined in my testimony and have in other things that I've written, this provision, in combination with a number of other provisions, such as the rate review and some of the benefit mandates, will lead to a dramatic reduction in the number of carriers, and thus when you move towards an oligopolistic market, if you've only got 2 or 3 big carriers, then everybody has an incentive to just say, well, we'll ignore it and we'll just, pass through the costs and pad our profits, particularly since they will be operating in a market where many of their customers will be subsidized by the government under other provisions of PPACA. So while in the short term I think Mr. Larson's economic analysis is correct, in the long term I think this is a very serious problem. Let me make an observation about the effects of the MLR that has not been brought up this morning in my oral remarks, and it is covered in the testimony that I submitted for the record. One of the big problems with this medical loss ratio or minimum loss ratio standard is it effectively constrains the amount of capital that an insurer can accumulate from their premium from after paying claims and administrative expenses, and that is going to lead, in my view, to a number of insurers simply exiting the market, particularly smaller ones. I discussed that in the testimony. It will very dramatically prevent or hinder new insurers from being created because it's not possible for an insurer to run a loss and then recoup it in the initial startup phase anymore. So the first thing that this does is kill off any new insurers entering the market. Parenthetically, I would say, I didn't cover this in my testimony, in my written testimony, but on another subject, we have another provision of PPACA that's trying to create new co-op insurers. This actually works against doing that. There are a lot of things that work against doing that. And then finally, and I think most perversely from the perspective of proponents of this legislation, it severely disadvantages nonprofit insurers relative to for-profit insurers, because nonprofit insurers, if you look at a market where you want to consolidate to the point that you're too big to fail, which is I think where insurers are going to go in with PPACA, nonprofit insurers don't have the wherewithal to do it. They can't raise the capital other than what they retain from premiums, whereas for-profit insurers can go into the equity market, issue shares, and buy up the nonprofits. So when I look down the road and say, well, what does the world look like in 15 years or 10 years, if you stay on this course, it looks like maybe 3 national insurance companies, all for-profit, doing everything. And they're really going to function like Medicare fiscal intermediaries, where they just pay the claims and don't care and leave it to the government to worry about the legitimacy and the cost of it. That, I think, is very debilitating and is, I think, the single biggest reason why Congress should repeal this set of provisions. Thank you for your time.
Chair,
I'll be happy to answer questions.
Chair, thanks, gentlemen. We are voting on the floor at this time, so we'll try to get through another presentation, and if it's all right with the ranking member, we'll break and come back. Is that okay? Yeah, we have 2 votes, unfortunately, so we're going to have to go. And we can't fill the chair. So, Ms. Turner, you're recognized for 5 minutes.
Try to be quick. Thank you, Mr. Chairman. Thank you, Mr. Pallone and members of the committee. Many employers said that the assurances that their health plans would be grandfathered was a key reason that they supported the legislation, yet independent surveys and the administration's own estimates, as we've heard today, indicate that most employers will not be able to maintain their grandfathered status, and therefore I would argue that the rules that were designed to do that, therefore, are failing and are not achieving their goal. The grandfathering rules really box employers into a corner. They can't make changes other than minor modifications to their health plans to keep costs down without being forced to comply with expensive regulations that increase their health care costs. Health costs are directly related to creation of jobs, as we've talked about a lot today. Higher health costs put additional pressure on the employer's bottom line and increase the cost of hiring new workers. This is bad for the economy and bad for unemployed workers. Employers do work very hard to find the balance between keeping the cost of health insurance down and also offering benefits that employees want and need. Part of the way they're able to do that is by seeking bids from competing insurers and adjusting benefit structures on the margin. But under the grandfathering rules, employers are now very limited in what they can do to change benefits. That also means they're limited in what they can do to keep costs down. Many people argue that the ACA's restrictions are needed to keep employers from cutting benefits or imposing higher health costs on their employees and also providing these additional consumer protections. But employees are really the ones who are ultimately paying the price for these higher health care costs, since coverage is part of their compensation. A recent RAND study found that most of the pay increases that employees have received over the last 10 years have been consumed by health costs. The study found that the typical family had just $95 a month in real dollars more for non-health spending in 2009 than it did in 1999. In contrast, the authors say that if the growth rate of health insurance had simply kept pace with the regular cost increase general inflation, the family would have had an additional $5,400 a year to spend. So employees are really the ones paying the price for higher health care costs. Therefore, it's in the interest of both to keep health care costs down, and the grandfathering regulations issued by HHS restrict their ability to do that. There are many problems that need to be solved in our health sector, but it's important to follow the medical dictum to first do no harm in making changes. The chairman mentioned that legislation is being drafted to reverse the interim final rule. The administration itself recognizes that companies need relief from burdensome and expensive regulations that impact their competitiveness and their ability to generate revenues to create new jobs. And withdrawing the grandfathering regulations would be a very good place to start to achieve those goals. Thank you, Mr. Chairman. I look forward to questions.
I think we get through one more. Ms. Troutwine, you're recognized for 5 minutes.
Thank you, Chairman and Ranking Member Pallone. I appreciate this very much. As you know, the leadership of this committee invited me here this past June to talk about the desperate economic situation that the ACA's medical loss ratio regulation has created for the 500,000 health insurance agents and brokers nationwide. Unfortunately, I do not have a positive update for the committee today. The economic outlook for many health insurance agents and brokers, and I would emphasize health insurance agents, which are different from general purpose agents. The MLR specifically applies to those that work in the health insurance arena. The market continues to be bleak. As health insurance companies renew and revise their agent and broker contracts, it's clear that the financial situation for many of these people, many of whom are business owners themselves, is getting worse. Clearly, this problem started when the MLR regulation was issued in December of 2010. It's very well documented that that's when the problem occurred. That regulation mandated that health insurance carriers, as you know, treat independent agent and broker compensation as a part of health plan administrative costs, in spite of the fact that independent agents and brokers are not employed by health insurance carriers. They do run their own businesses, hire their own employees, pay all of their own office expenses, including professional liability insurance. Each agent decides on their own which health insurance carriers he or she will represent, and then they are retained by individual consumers and employers to assist them with their health insurance needs. Issuance of the HHS regulation on MLR, which categorized agent commissions as an insurer administrative expense, triggered, as I said, an immediate response from many health insurance companies, an immediate reduction in agent compensation. In May 2011, a national actuarial study conducted by the NAIC task force, it's the professional, not the whole NAIC, but the Professional Health Insurance Advisors Task Force that was assigned to address this problem regarding producer compensation, said that in 2011, a significant number of companies have reduced commission levels, particularly in the individual market, and this was reinforced by the most recent report from the GAO, Private Health Insurance Early Experiences Implementing New Medical Loss Ratio Requirements, which states almost all of the insurers we interviewed were reducing broker commissions and making adjustments to premiums in response to the MLR requirements. These insurers said that they decreased or plan to decrease commissions to brokers in an effort to increase their MLRs. As a result of these cuts, brokers serving individuals and the small business community, as has been said earlier, have seen their overall revenues slashed by 20 to 50%. This means that fewer of them are able to stay in business. It also means that those who are able to survive are being forced to make service cuts and are no longer able to provide the counseling and level of advocacy support to their clients that they have in the past. Now, it may seem to you that what agents and brokers do is simple. You may think that all they do is fill out a form and sign people up for insurance. And some of you may even think it's as easy as buying an airline ticket. But there is so much more than that. They meet with each client and determine their specific needs, covering everything from which doctors they use to their preferences for financial risk. They have candid conversations with people who are struggling to afford coverage and help them find ways to stay insured. With employers, they also discussed issues such as the savings that can be achieved through wellness and disease management programs and the characteristics of a particular company's workforce, discussing options for structuring their coverage. This dire situation is why we are looking at all possible solutions, whether they are regulatory or legislative, to address the problem. This problem needs to be addressed both quickly and in a way that's politically viable. And there's a solution that we believe meets both of these requirements. We believe that if agent commissions, since they are not really an insurer expense, were removed from what is currently defined as premium for MLR calculation purposes, either through a legislative act or regulatory action, that it would significantly improve the situation that exists today. I'm sure that you all are aware of H.R. 1206, which now has 120 bipartisan co-sponsors, 24 members of this committee. It is authored by Mike Rogers, and Congressman Barrow, and we definitely appreciate them having done this. We endorse this as well as do all other national agent professional associations, and as well as I said, the NAIC Broker Task Force. And I'll stop there.
Chair, thanks. Gentlelady, we are going to recess at this point. We've got about 4 minutes left. I want to thank the witnesses for their patience. We have 2 votes. We'll be right back to reconvene after the second vote. Subcommittee is now recessed. Subcommittee will come to order. The Chair recognizes the Ranking Member Emeritus, Mr. Dingell, for UC request.
Mr. Chairman, I have unanimous consent requests that a letter signed by Charles M. Lovelace, Director of Legislation for AFSCME, be inserted in the record, and also that a statement from Representative Tom Price of Georgia be inserted in the record at this point.
Without objection, so ordered.
Thank you, Mr. Chairman.
Thank you. We'll go back to the panel. Mr. Potter, you're recognized for 5 minutes for testimony summarization.
Mr. Chairman and members of the committee, thank you for this opportunity to be here today. My name is Wendell Potter. I'm Senior Analyst at the Center for Public Integrity and former Head of Corporate Communications at Cigna Corporation. The views I express today are not necessarily those of either employer. For 20 years, I worked as a senior executive at health insurance companies. During that time, I saw how these companies confuse their customers and dump the sick to satisfy their Wall Street investors. The top priority of for-profit companies is to drive up the value of their stock. The stock price of the big for-profit insurers fluctuates based on their quarterly reports. Investors and Wall Street analysts look for 2 key figures: earnings per share, which is common to all companies, and the medical loss ratio, or MLR, which is unique to the health insurance industry. As you know, the MLR is the ratio between what an insurer actually pays out in claims and what it has left over to cover executive pay, underwriting, lobbying, sales, marketing, public relations, other administrative expenses, and, of course, profits. Within the executive offices, there is a single-minded focus on being able to show investors and analysts that the insurer made more money during the previous quarter than a year earlier, and that the portion of each policyholder's premium devoted to covering medical expenses was less than it was a year earlier. Insurers almost always see sharp declines in their stock prices when they disclose that they spent more money on medical care than investors expected. I remember vividly when Aetna's stock price fell more than 20% on the day that it admitted that its first quarter MLR had increased from 77.9% to 79.4%. Studies done by the accounting firm PricewaterhouseCoopers have shown how successful insurers have been in meeting Wall Street's MLR expectations. One such study found that the average MLR in the insurance industry has fallen from approximately 95% in 1993 to around 80% today. That translates into a difference of several $1 billion in favor of insurance companies' shareholders and executives, and at the expense of health care providers and their patients. The provision of the Affordable Care Act that requires insurers to spend at least 80% of what we pay in premiums on our health care is one of the most important provisions of the law and one that must be preserved. Some have suggested that if the entire MLR provision is not repealed, Congress should at least exempt insurance agent and broker commissions from the calculation. And the bill introduced by Representative Rogers would take that a step further by excusing all sales commissions, including payments to salaried sales staff, from the formula. To make it even easier for insurers to meet the law's requirements by exempting broker commissions is precisely the wrong thing to do. It's important to note that even before the passage of the Affordable Care Act, insurers were planning to take steps to reduce broker commissions anyway, which they viewed already as too high. A recent filing from the state of North Carolina revealed that Coventry had reduced its commissions on first-year policies from 27% to 14%, and that Cigna had cut first-year commissions from 20% to 12%. My question to brokers is this: did you really deserve 27% of your clients' premiums? Another point, insurers are not being forced by the MLR provision to reduce commissions. There are other levers on the administrative side or through reducing premiums. Basically, insurance companies have been choosing to reduce commissions to protect profits. I doubt you have heard of any insurers that have reduced the salaries of their CEOs and other top executives to meet the MLR requirements. You haven't, and you won't. Another thing to keep in mind as you consider legislation to exempt commissions from the MLR equation is that even if it were to be enacted, it is not likely to be of much help to agents and brokers now or in the future. Insurers will not restore the commission reductions they've already made. Exempting commissions would only help insurers by making it easier for them to comply with the MLR provisions. The proposed changes to the grandfathering provision are similarly misguided. By denying the Department of Health and Human Services the ability to enforce insurance reforms on current plans, the bill would take away important consumer protections, including the prohibition on lifetime limits and the ban on rescissions, a practice that lets insurers take away your coverage mid-year, usually after you've gotten sick. It would also prohibit enforcement of the rule that allows young people to stay on their parents' insurance plans until age 26. This week's census figures show that this provision has already helped 500,000 young people get insurance. Why would Congress take away their coverage? HHS carved out reasonable limits on what plans could be grandfathered. A plan can maintain its grandfathered status until it changes its benefits or raises its costs too much. This proposal would remove those limits so every plan is grandfathered forever. This means that people will be locked into the plans that don't have the protections they're entitled to under the ACA, like preventive medicines, without co-payments. The final point, if you pass the bill to repeal the grandfathering provision, you will be guaranteeing that millions of Americans will absolutely be facing the loss of the coverage they have. If my insurer is able to cut my benefits and hike my premiums and deductibles, actions that in the industry are referred to as benefit buy-downs, that means that I will not have the same coverage I had or was happy with. Thank you, Mr. Chairman.
Chair thanks the gentleman and now recognizes Ms. Quincy for 5 minutes for opening statement.
Thank you for having me here today. My name is Lynn Quincy, and I am the Senior Health Policy Analyst at Consumers Union, which is the independent nonprofit publisher of Consumer Reports magazine. And our mission is to provide consumers with unbiased information about goods, services, health, and personal finance. I'm here to discuss the proposed changes to the grandfathering regulations and medical loss rules called for by the Patient Protection and Affordable Care Act. And I'm here to ask the committee to take a holistic look at the impact of the proposed legislation and to holistically look at its impact on consumers. The proposed legislation addressing grandfathered plans would undermine the Affordable Care Act's consumer protections in two ways. It broadens the definition of plans that qualify as a grandfathered plan, and it calls for a blanket exemption of these plans from all Affordable Care Act requirements. If enacted, this proposal would leave many consumers worse off. You've heard many examples today already about how, for example, the impact on adult children up to age 26, or the current requirement that plans all present a uniform health insurance disclosure form to consumers so that they can better understand their health plan features. If enacted, this proposal would create a bifurcated market. In 2014, consumers wouldn't have the security of knowing that all their health insurance choices provide a minimum level of coverage and have understandable and uniform caps on out-of-pocket spending. Instead, anyone with access to a grandfathered plan would have to learn two insurance markets, the one featuring the new consumer protections and the one in which none of the Affordable Care Act provisions apply. The proposal expands the definition of what constitutes a grandfathered plan, stripping away all requirements for maintaining reasonably similar cost-sharing levels. And let's be clear about what we're talking about here when we discuss whether an employer's ability to lower costs. What we're really referring to is employers' ability to shift cost onto employees. And believe me, that's not what consumers want. The things that are driving healthcare premium increases, you have to look in other areas besides these new provisions and the MLR. And there's nothing more serious that this committee should be doing. I've just returned from Wyoming, where a broker described a 10-person dental office that just received a 56% premium increase. And he speculated that it was due to the fact that someone in that 10-person group had contracted Graves' disease. These are the problems that you need to be addressing. We regularly hear from consumers about their health coverage, and I'd like to assure this subcommittee that we have not heard a single consumer clamoring to keep their health plan as cost-sharing rises over 18% a year, the approximate limit at which they might have to give up their grandfathering status. I'm sorry. Got to find my other page. We also oppose legislation that would repeal the medical loss ratio provisions. These provisions are working to improve value for consumers, as you've already heard today. Placing a floor under health insurers' MLR is not new. Roughly a third of states have enacted rules that require plans to spend a certain percentage of their premium dollar on medical care, and that provides us with significant, credible experience about how MLR regulations affect consumers and brokers. And as you've already heard, there's early evidence that the federal rule is working to improve value to consumers to address those rising premiums that are of such great concern. We note that the evidence with respect to overall broker compensation is mixed. You've already heard about the NAIC study and the fact that they declined to support legislation that would carve brokers' commissions out of the MLR. Today's MLR rules provides needed transparency. Steve Larson talked about this, and this is really important. I think this would appeal to both sides of the aisle as we move forward. We need to understand what goes into those rising premiums so we can better understand how to clamp down on them to help consumers. Finally, today's MLR rule is not a blunt instrument, as the proposed legislation would be. It provides targeted evidence-based relief to states. They can apply for an adjustment, as we've all discussed. And some of the states that have applied for adjustments, like Maine, already have an oligopoly that has nothing to do with the proposed MLR rule. There are structural problems in the insurance market, to be sure, but I'm not really expecting the MLR rule to contribute greatly to those problems. My written comments go into greater detail about the benefits of our grandfathering rules and MLR rules as they exist today. Thank you for the opportunity to speak to you.
Chair, thanks, the gentlelady. Thanks all the witnesses for their patience. We will now begin the questioning from the members, and I'll begin by recognizing myself 5 minutes for that purpose. Ms. Troutwine, some argue that insurance agents add no value to the system and are simply overhead in the system that can be eliminated at the stroke of a pen or regulation. Can you elaborate on the role agents play in our healthcare system?
Absolutely. Well, first of all, it is true that agents do help people secure health insurance coverage. They counsel their clients on the appropriate types of coverage, what is available in the market, what they can afford, both individuals and businesses. But where their jobs really kick in is after that coverage has been placed, because if there is a claims issue, if there is a billing issue, if there is a question about a regulation, and I can tell you right now our members are very busy advising businesses in that area, any of those things go through the broker. In fact, I saw a recent study from SHRM, which mainly serves larger businesses, that the primary place that they are getting their information about health reform comes from their broker. And so things like that, advice on compliance, on regulations, taking care of claims. And I mentioned this during the last hearing, but this issue of taking care of claims is significant. When I was a broker some 20 years ago, I never, ever had any of my clients have the need to go to the appellate process through their insurer because we were able to address it quickly. And that's what our members and other brokers do every day.
Thank you. Ms. Turner, can you explain how the grandfathering rule diverts the resources of employers towards more expensive health coverage and away from capital investment, wage increases, and job creation?
Well, as I mentioned in my testimony, if employers are not able to stay within the grandfathering provisions, then they're required to provide a number of other consumer protections, such as no out-of-pocket cost to employees for preventive care, for example. This is going to increase the cost of health insurance, and so that's why I feel there's really sort of a catch-22 for employers, that they find that they need to make changes in order to keep their costs down, but if they make those changes, then they're subject to another list of rules through PPACA. And these do divert capital, and I think it really is important, as Ms. Quincy was saying, we really do need to take a holistic look. That when you move employers, and I've been a small business owner for 30 years, or running small businesses for 30 years, you don't look at things in silos. You look at the bottom line. And if health care costs are rising, then you're going to have to figure out what can you do on the other side. And sometimes you don't hire that extra worker, or you don't buy that new piece of equipment. So it really does impede employers' ability to make the right decisions for their business.
Thank you, Mr. Hasselmeyer. In December of 2009, the Congressional Budget Office released a paper stating that a legislative proposal to set an MLR of 90% would make health insurance an, quote, essentially governmental program, end quote, in combination with PPACA's other provisions. Do you believe that a slightly lower MLR of 85%, like the one included in PPACA, will give the federal government functional control of private health insurance in America?
I don't know that the percentage makes as much difference as the structure of the regulatory design. As I pointed out in this regulation for minimum loss ratios, but also coupled with the other regulations, the additional benefit requirements, the rate reviews, et cetera, do shift the industry to a regulated utility model. In fact, it's interesting that President Clinton's health advisor, Sarah Rosenbaum, who is well known in this area, wrote a piece in defense of the individual mandate that essentially argued that, well, yeah, the individual mandate, and she was, I'm not interested, talking about the legal question about the individual mandate, but she was basically made the point in that piece for I think it was the Journal of American Medical Association, New England Journal, that this design in PPACA turns insurers into a regulated public utility, and I agree with her on that. What she didn't discuss is the economics of a regulated public utility, and the economics are, in that world, as a competitor, you either want to be too big to fail. You want to be one of the last two or three left. That yes, you're going to be regulated, but they can never put you out of business because they need you to be in business, or otherwise people don't get the service. That's why people scream about power companies, and we had this with the storms, but they never actually drive them out of business. Well, once you get to that kind of a world, you don't care what the costs are. You just pass them through because your customers have no other choice. And that's the world we're headed to with these regulations. So, yeah, I see that happening.
Thank you. My time has expired. Chair recognizes the Ranking Member Emeritus, Mr. Dingell, for 5 minutes for questions.
First, I'd like to compliment you, Ms. Quincy, and Mr. Potter for your very fine statements. Thank you. This question, Mr. Potter. The law requires health insurance companies to pay rebates if they spend fewer than 80 to 85% of their customers' dollars on health care and quality improvement activity. The Department of Health and Human Services estimates that the new minimum MLR law will result in consumer rebates to as many as 9 million people, up to $1.4 billion in the 2011 plan year, and up to $4.9 billion in the 2011-2013 plan years. Agents and brokers are heavily lobbying for special exemption for being included into the medical loss ratio calculation. The fact is some agents and brokers are really providing valuable and helpful services, and I happen to agree with that statement. But they, like other costs within the insurance products, they should compete and keep costs competitively low as possible for consumers. At a time when everybody's being asked to tighten their belts and find and create efficiencies, asking for an exemption from these pressures, particularly at the expense of consumer pocketbooks, is not something that I think the consumers will take kindly to. Mr. Potter, would you please talk to us about the dangers of exempting agent and broker commissions from the medical loss ratio calculations and what types of commissions that they have been getting over the past years?
Thank you, Congressman. Yes, if they're exempted, it will be, as I said in my testimony, really a gift to the insurance industry because it will give them just one more way that they can meet regulations that they could already be meeting if they were to reduce benefits, reduce premiums, or if they were reduce spending in some of the many other areas of spending. McKinsey & Company did a study a few years ago showing where most of these companies' administrative costs really are, and they are in underwriting, they're in sales and marketing, and things of that nature. So my own salary, for example, was an administrative expense. In fact, I was talking to someone in France not long ago who said my job was unknown in the French system, and I could understand that. But there are a lot of other places where cuts can be made. And yes, I agree with you. I think brokers, agents and brokers have indeed provided in many cases, good value to the people they serve. But they do get their income from insurers, and they have been paid handsomely. And I think that they should be expected to give up some of, to sacrifice just as much as everyone else.
Thank you. I've got a bunch of questions, and I apologize. I don't mean to curtail your testimony. Ms. Quincy, Consumers Union expanding the consumer protections indicates that that this has had a negligible impact on premiums. My colleagues on the Republican side claim that this is an enormous burden to health plans and employers and use that as a rationale for repealing key elements of the Patient's Bill of Rights for many people. First, and these are yes or no if you can please, do you agree that the new consumer protections are imposing a huge burden on health plans and employers or not?
I do not.
Okay. Do you have any estimates or examples of how much these provisions would cost?
Yes, I'd like to refer the committee to my written testimony, if I can find the page. We provided, I think, 3 or 4 sources that cited some actuarial estimates about what the cost of the various consumer protections are. And I think I have to go one page further to get there. Here we go. So in the written testimony, I talk about the fact that federal agencies have estimated that ending annual and lifetime limits will increase group premiums by about 0.5%, and it will increase non-group premiums by less than 1%. Prohibiting pre-existing exclusions for children is estimated to have a negligible impact on premiums. A recent Anthem Blue Cross Blue Shield filing for the individual market in Connecticut shows that the new protections from unjust rescissions have had no impact on premiums, and ending lifetime limits has also benefited consumers without raising costs. And for the sources for those statements, I refer you to the written testimony.
Thank you. Now, Mr. Potter, very quickly, can you discuss insurance company practices with regard to individuals with pre-existing conditions prior to the passage of the Affordable Care Act, and what can we expect since the passage of these new protections? In other words, what's it going to do to costs? What's it going to do to consumers? What's it going to do to industry?
Insurance companies for many years have refused to sell coverage to people with pre-existing conditions, and it is something that continues to go on right now, except for children. That already has gone into effect. A Chattanooga newspaper recently disclosed that Blue Cross and Blue Shield of Tennessee, a nonprofit supposedly, refused to sell coverage to about 1/3 of applicants largely because of pre-existing conditions. It's been something that's been a leading reason why we have now more than 50 million Americans without coverage. And it doesn't matter whether you're rich or poor. I once found...
you just don't get insurance if you've got a pre-existing condition.
Exactly. If you've got a pre-existing, you're just out of luck, even if you were born with that pre-existing condition.
Okay. Now, I guess my time has expired, Mr. Chairman. Thank you.
Chair, thanks, gentlemen. Recognize Vice Chairman Dr. Burgess for 5 minutes for questions.
Thank you, Mr. Chairman. You know, done a lot of thinking this summer about the summer of 2009 when we all went home after this committee passed H.R. 3200, which was the House version of the health care bill. That version has died a natural death, and Harry Reid's version is the one that was signed into law by the President. But the things I remember being asked at those town halls, and they were difficult, and they were loud, and they were long, and they were hot, but those town halls, people said, first off, don't do anything that's going to mess up the system that exists and works for arguably 60, 65, 70% of us. And we didn't do that. We screwed it up. Witnessed a large number of waivers that are in effect now, and people concerned about issues like grandfathering. And then the other thing they asked, and they were really clear on this, was can you do something to help us with costs? Because we are concerned about the cost of health insurance. And as I looked around the country, the one place where really cost had been addressed in a very effective way. It was the state of Indiana and Governor Mitch Daniels with his Healthy Indiana plan. And for the life of me, I don't know why we did not subpoena him and bring him to this committee and chain him to the chair until he spilled the beans as to how he was able to hold health care costs for his state employees down by 11% over the previous 2 years. So, Ms. Turner, you're familiar with Governor Daniels' plan. Could you very briefly encapsulate what is embodied in that?
Well, Governor Daniels, and particularly the Healthy Indiana plan, but he also has incentivized state employees to enroll in consumer-directed plans. And what he's recognized is that if you engage consumers as partners and really giving them more information so they have the ability to make decisions and to use better information to make better decisions, that they really will become partners in helping to manage costs. And we've seen it across the board. I have a section of my testimony when I talk about a new study by the National Business Group on Health, and it found that companies that offered account-based health plans, whether health savings accounts or health reimbursement arrangements, had costs that were $900 lower on average for individuals and $2,885 lower for families. So the reason that the number of employees that have joined these plans is rising is because they really do help to hold down costs, and employees become partners. They are more likely actually to use preventive services when they have a health savings account than they are in regular insurance, because as one said, I realize that if I take better care of myself, I'll save money in the long run. So they provide the right kind of incentives, transparency, and give employees an incentive to be partners in managing costs.
Now, as I understand for Governor Daniels' plan for state employees, he actually funds the health savings account that's associated with that high deductible plan. Is that understanding basically correct?
Yes, they put money into the health savings account, and with the Medicaid expansion, their Healthy Indiana plan, both the state and the individual share in funding that account. So they really do have a stake in.
And of course, the phrase I've heard associated with that is something magic happens when people spend their own money for health care, even if it wasn't their own money in the first place. But perhaps, Mr. Hesselmeyer and Ms. Turner, you can talk about how the MLR regs affect consumer-directed health plans, and perhaps the one place we should have gone that we didn't go in the health care law. What's the future ahead for consumer-directed health care under the MLR?
Well, this is one of the areas where, as your colleague, Representative Cassidy, pointed out, there are some problems with the way the statute was drafted because it didn't take into account the fact that if you have a consumer-directed plan where of the total spending that the individual is doing, more of it is going directly from the individual to the provider and less through the insurer, then the insurer for that portion that they're handling is going to have, by necessity, a higher administrative costs and are going to be penalized for that product design. So it's correct that it will favor product designs that are more comprehensive, meaning that more of the total spending goes through the insurer's hands. There are other places that practitioners in this area have encountered. I remember this from a former colleague who was a Democratic insurance commissioner, and saying that one of the problems they ran into is they're running into things like when you have overseas employees and you provide them medical care. If you want to send somebody to be an oil worker in Nigeria or something, you're not only going to have to pay them well, but you're going to have to make sure they're going to be worried about, well, hey, you're sending me off to work on an oil platform in some third world country. What happens if something happens to me medically? Well, these are not administratively cheap plans to run because you're going to have to airlift them out of there. You're going to have to do all this other stuff. So under the MLR, those plans are disadvantaged. The other thing, I mean, you just keep compounding this. This one that this fellow was pointing out to me, he's an insurance law practice now, was another client where it was a church that had missionaries who aren't employees. Okay, but they are providing them with health benefits. So how does that get handled? So you've got a lot of problems in this. If I could just make one point, because I think it's really important to understand that disclosing, as I said in the testimony, this information is fine, okay? If you want to put this information out, states already have the data to do that, and I think states should put it out and let the consumer say, is this, this is one more piece of comparative information. It's only when you set a standard that says, well, you have to do this minimum, that you create these problems. So I would present to you a hypothetical, and let's just think about this, if you'll indulge me. We have let's take two insurance plans. We'll call them, two situations. We'll call them A and B, okay? Under both scenarios, the plans cover the same benefits. Okay, so they're not a difference in lesser benefits or more benefits. Yeah. Under both scenarios, you're going to pay about $1,000 for out-of-pocket deductible copays. Plan A charges $5,000 and has an 80% medical loss ratio, meaning $1,000 is retained and $4,000 goes to paying claims. Plan B charges $4,000 and has a 75% ratio, meaning they keep $1,000 and $3,000 goes to claims. Which is the better buy? Do you buy the plan with the higher loss ratio but $1,000 lower premium? Or do you buy the plan with the higher lower loss ratio, the better loss ratio under this scenario, but a $5,000 more expensive? You see, those are the kinds of decisions consumers have to make. As a piece of information, that's fine. But when you say everybody has to fit into this box, you have a problem. Thank you, Mr.
Thank you, Mr. Chairman. I'll yield back.
Chair, thanks, gentlemen, and recognize the gentleman from Louisiana, Dr. Cassidy, for 5 minutes of question.
Mr. Potter, if I've been smiling at you the whole time, it's nothing inappropriate. I'm reading Harry Potter to my 10-year-old right now, so we spent 15 minutes on the phone last night. She would be disappointed you don't have a scar on your head. I read your testimony. It's very compelling. But you could want to remove power from insurance companies and not necessarily be for the ACA. That's a fair statement. And one of the reasons why I like consumer-driven health care is because it truly moves the locus of power from a bureaucrat, whether it's Washington, D.C. or elsewhere, to the consumer. You're the numbers guy. You're the fellow who used to help an insurance company look at things. Looking at your testimony, and your testimony was almost that an insurance company is an organic organism which is going to move to maximize profits. Let's take Mr. Hasselmeyer's just assertion. This MLR seems to reward companies that sell higher-priced policies because your 15% of a higher priced policy is a greater absolute amount than 15% of a lower priced policy. And again, the consumer-driven health care plan, you don't start paying claims until someone's paid their HSA and they're out of pocket, and then you move into it. So just your thoughts on that. Again, looking at your testimony, it seems that I would draw from that they would react in such a way as to preserve their profit margin, which means that they would be prejudiced towards a higher price policy.
You have to consider the cost of insurance, including the cost of what you have to pay out of pocket. If you just keep premiums in isolation, then it skews what is really the obligation of the person who has that policy. Another point, too, is that...
No, but I don't follow how that answers my question. And no offense, but I don't see... Again, my assertion is that if you artificially restrict MLR and not account for the absolute, as Mr. Hasselmeyer's example, we got a cheaper policy, $4,000, but if it's $1,000 for administrative costs, that's a 25% MLR. We are prejudiced against that policy towards one which is $5,000 and now meets this artificial MLR requirement. Would you disagree with the example he just gave?
I would.
And I don't follow why.
Because, again, you have to consider the value that the person has in the policy. If you're paying a certain premium, yes, there's no doubt the account-based plans typically have a lower premium, but there is greater cost shifting from the employer or the insurer to the...
Now, there is a Kaiser Family Foundation study, either there or a CRS or a GAO, I forget which, I'm digging up out of my memory, which shows that those who have consumer-driven health care plans with an HSA have $500 extra out of pocket relative to a traditional policy, but because their premiums are 25 to 30% cheaper, net they're $2,000 ahead. So they also found that those patients with a HSA and a high deductible access preventive services as frequently as do those who have a traditional policy. They also found that 50% of those in this particular survey, I'm remembering, so I may have it a little wrong, were previously uninsured. Cost lowered by 25 to 30%. Previously uninsured people now have the ability to purchase insurance, and they're accessing preventive services as frequently as those who have traditional policy. That sounds like a good value to me.
It is for some people, but some of the other studies you might have seen too show that many people who are in these kinds of accounts don't have the money to meet that deductible. A lot of employers are benevolent, and they do provide some money to pay that deductible. People who are in the individual market, like my son, don't have that ability. He was forced to buy a high deductible plan.
How old is your son?
He's 28.
Now, reasonably speaking, a 28-year-old without chronic medical condition made a wise financial decision, correct?
Here's what happened. He was told that he would have to be moved out of his plan, which had a $500 deductible, to one that had a $5,000 deductible, or his premium would go up 67%. And my son has asthma, and so, yes, he is going to be paying quite a bit out of his own pocket. He doesn't have a very high...
But what was his savings on his insurance policy? Because net, if he's paying $3,000 less...
$2.12 a month was his savings, but he is facing a deductible that's 10 times this much.
No, I'm sorry, that's $2,000 relative to his previous savings, but it's not $2,000, it's more than $2.20 to what his premium would be. I guess that's my point.
No, sir. The math is that by moving out of the plan that he was in to the one that he moved into, his premiums were about the same, actually maybe $2 less, but his deductible, his total out-of-pocket expenses over the year is considerably more.
I guess I'm a little confused because if he had stayed in his previous policy, his premiums would have been substantially more.
That was not available to him. He was forced out of that plan, just as I was a few years ago, Congressman. I worked at Cigna for quite a few years, and I had a plan that I liked. It was a PPO. Cigna decided, didn't ask me, Cigna decided that it would move me and every other employee out of the PPO or the HMOs into an account-based plan. For me and for the CEO, that's fine. And for the executive board of GE, that's perfectly fine. But most of the employees of Cigna make far, far less than 50,000.
We're almost out of time, we're almost out of time, and we're about to start getting the clump on us. But let me just respond again. The Kaiser Family Foundation study suggested that most people with HSAs have modest incomes, $70,000 or less, and that their out-of-pocket, their global cost decreases over the year by a couple $1,000s. And again, they're accessing preventive services as well. I would be interested if you have data which shows, and this will have to be an off-the-record answer, that shows there's any difference in outcomes. Because people point to the anecdotes, but I don't find that there's any data on difference in outcomes.
Yeah, you're right. We could take a look at that more closely, but I think people who are healthier do gravitate toward these plans.
I think the data shows that even people now who are not as healthy are doing as well. But
because they're being forced into these plans against their own.
No, but I'm talking about outcomes and their pocketbook. Anyway, I think we're out of time. Thank you.
Gentleman's time has expired. The chair recognizes the chairman emeritus for a follow-up.
You are most kind, Mr. Chairman. Thank you. This goes to Mr. Potter and Ms. Quincy. Our colleagues on the other side of the aisle are portraying the discussion draft as a means for Americans who like their health coverage to keep it. In fact, the legislation is much broader. The real intention appears to be to eliminate the insurance reforms enacted by the Affordable Care Act and to put insurance companies, not patients, back into control. Would it be accurate to say that this legislation is another way to repeal health reform? And am I correct in my first assumption? Yes or no?
Yes.
Ms. Quincy? Yes or no?
It would greatly undermine the various provisions of the Affordable Care Act that are expected to work together.
Good. Now, does the legislation that we're discussing here allow patients to keep their insurance if they like it, as claimed by my Republican colleagues, or are the insurers really in charge of being allowed to cut benefits, increase cost sharing, and make other changes? Which is the case?
If the discussion draft were enacted, it would permit tremendous latitude with respect to self-insured employer plans and insurers to make changes in benefits, some of which would certainly include cost shifting to employees.
Mr. Potter?
Absolutely. As I said in my testimony, if you pass the repeal of the grandfathering, you can absolutely guarantee that people who have coverage now, their coverage will change significantly in the near future, if not the long term.
Now, as I understand this, what we're essentially doing is setting up two categories of insurance carriers. The first category would be those who are grandfathered. The grandfathered plans would be able to do most anything they want and achieve strong competitive advantage over the latecomers who would not have that privilege. Am I correct?
Yes.
Is that right, Ms. Quincy?
Yes, there's certainly.
And that would lead then to very significant advantages to the first category and a strong discouragement to the second category going into this business. Is that right?
Well, my greatest fear would be the segmentation of risk, since two different insurance markets exist side by side. I think that's the greatest danger. And
you would tend to see all the bad business being shoved into the second category that weren't grandfathered. Is that right?
Yes,
yes,
unless you are.
All right.
Yes, you're correct.
Now, if you've got a plan that is grandfathered, it would be able then to charge lower prices for its product and give less benefits at the same time. Isn't that right?
Yes.
Yes.
Okay. Got another question? Let's raise one of the more problematic issues with this legislation. Consumers in grandfathered health plans, including those that have raised premiums, cut benefits, or increased cost sharing, would not have any federally guaranteed rights to internal and external appeals. Is that right? Appeals. Is that right?
Yes.
So they could kick them all around the block and they couldn't complain. All right. This creates an environment then where insurers, not health professionals, will be making treatment decisions without opportunity for outside review, bottomed only on the situation where some eye-shaded actuary in an insurance company would be defining what treatments the guy could get. Is that right?
Particularly in self-insured plans.
Okay. Now, doctors have said all along that the Affordable Care Act is turning the doctor-patient relationship into a patient, or rather, I'm sorry, not the doctors, but my Republican colleagues have said that it's turning the doctor-patient relationship into a patient-government relationship. First of all, is that true, yes or no?
I'm sorry, the question is, does that interfere with the doctor-patient relationship?
Yeah,
when you
does
can't
this
have,
bill,
don't have
does
a
this
right
bill interfere with the doctor-patient relationship? I'm talking about the Affordable Care Act. Does it interfere with the doctor-patient relationship?
I think that you could say that to the, because at least around 50% of
all it really does, Ms. Quincy, is to define the rights of the patient, and then within that new definition, the patients and the doctors decide what they want to do. And one of the noteworthy things is that the medical profession supported this particular thing after years of having complained about the need to protect us against interference in that relationship. Is that right?
Yes, Congressman. The Affordable Care Act provides additional means of getting redress if you've been denied coverage your doctor orders.
Okay. I'm going to ask you now, because I get just one more question, Mr. Chairman.
Seeing no objection, the
All
gentleman
right.
is awarded an additional minute. But I caution you about statements about the AMA. I am a member, and I'll yield to the gentleman.
I'm not a member, but I'm a good friend of the AMA, and all I'm doing is defining what it is they had to say and do.
And I appreciate you doing that. We're going to have an opportunity to talk about that a great deal more in the future.
And I say this with great respect for my friend from Texas. Now, what I want to know is it important that we give guaranteed internal and external appeals rights to the patients who would have benefits under a plan and were being treated in a way they didn't like by the insurance company?
It's critically important. A GAO report shows that at roughly 50% of coverage decisions that are disputed using the appeals process are reversed. So that means a mistake was made by the insurance company. So it's critically important, right?
It is.
Mr. Potter?
It is, and it's an essential benefit of the Patient's Bill of Rights that was that Congress considered many years ago, and it's about time that Congress enacted it.
Mr. Chairman, I thank you for your kindness.
Thank the Chairman Emeritus for his walk down memory lane. I need to remind the Chairman Emeritus that it was an amendment that he and I put into H.R. 3200 that would enshrine the rights of internal and external review. The Speaker of the House stripped that provision out of the bill that went from this committee on July 30th to the House floor to vote on November 9th of 2009. The Senate did provide some coverage, but it was pretty watered down and nowhere near as expansive as the brilliant amendment offered by the Chairman Emeritus and the Vice Chair. And it was a shame because Texas has led the way on this.
If the gentleman would yield,
yield.
My good friend is just indicating how well we work together.
There you go.
And the fine consequences of that kind of effort. I'm here to say I'm anxious to work with the gentleman if he'll stop pushing this kind of nonsensical legislation. I'm sure working together we can come up with something much better.
It was our opponents in the Senate that prevented us carrying the day on that, as well as the Speaker's office and the White House probably had some interference. But nevertheless, we are where we are. And let me just ask you, Mr. Potter, I think you testified or provided your written testimony that Congress has exempted all taxes from the MLR calculation. Is that correct?
I don't think it's in my written testimony, but there's much that has been exempted in the MLR calculation. That's correct.
But by regulation, working the MLR regulation at HHS, they decided to sort of pick and choose which taxes are exempt from the calculation. Do you feel that that's inconsistent with the intent of the law?
I think that the statute was pretty clear that certain taxes are exempt from the equation. I can't tell you which ones in particular would qualify for that. That was the intent of Congress, as I understand it.
I don't have the page number, but in your testimony, the statement is, in addition, Congress exempted all taxes from the MLR calculation a huge artificial boost to insurers' MLRs.
Exempting taxes is a boost to MLRs.
Well, again, the impression given that all taxes, but HHS did not see it that way. Mr. Outwine, let me just ask you, one of the things concerns a lot of us on this thing, and there are obviously a lot of things that concern us in the Affordable Care Act, but the cost is a big one. And we had estimates of costs all over the place, but I think no one now believes those figures that were originally delivered to us by the CBO. And even the chief actuary for CMS has said the cost is going to be some $450 billion over 10 years, higher than what was advertised in March of 2010. And in fact, those numbers are probably higher still. And the difficulty is, of course, the Congressional Budget Office having to estimate how many people would leave their employer-sponsored insurance, or how many employers would drop employer-sponsored insurance and push their employees into the exchange. So do you think that the number of people ending up in the exchange will be greater than currently estimated? Do you have has your organization done any looking at this?
Well, thank you very much for this question. I'm very glad you asked that. This is actually one of our primary concerns, not so much whether they end up in the exchange or somewhere else. We're very worried about what we're seeing in terms of some employer decision-making process. So if we calculated the cost of this legislation, it being whatever the final number was, modified 3 times over by CBO or whomever, if that is all based on some assumptions that, frankly, we are very worried are not correct. What we're seeing is many employers saying, look, the burden is too heavy. And I've talked to them personally. This is not anecdotal. They're saying, we are doing the numbers. We're afraid that we can't do this anymore. Now, if too many of them do this, of course, all the estimates that we made relative to the cost of providing subsidies for a group of people that did not have employer-sponsored coverage is going to mushroom dramatically. And so what we're thinking is that many of them are not going to be providing coverage it did in the past, far more than were estimated to be dropped in the original calculations. So and this is based on massive input from our members and their clients. And we're working hard to keep them from doing this, but frankly, some of it is the train has left the station.
Yeah, no one wants to be first, but nobody minds being second in that race. And it's akin to sending one of those rocket ships to the moon. If you're off by only a few fractions of a percentage of a degree, you end up at Saturn, and I'm afraid that's where we're going. I want to thank everyone for attending. That appears to be the conclusion of all the questions, and I want to thank the witnesses for participating in today's hearing. Thank them for their indulgence while the floor did votes. I remind members they have 10 business days to submit questions for the record, and I ask the witnesses to respond promptly to these questions. Members should submit their questions by the close of business on September 29th, and the subcommittee stands adjournment.